He's on? Okay.
Okay, you can do your test now. Okay, remote.
Mr. Lynch is on.
He's on.
Yeah, so I will just,
Okay, so
so I'll hand over to him. I'll just do the basic welcome.
okay, so you don't need
No,
it.
I don't need it. So I'll just do the basic welcome and
Yes.
hand over to him.
Okay, ready to go. The typography have two names, my name and my father. Um, you're starting on something new.
Sure, sure. Mhm. Good morning, everyone. Welcome to the second day of our 12th Annual National Health Research Conference. We have a wonderful day ahead, and we expect again a full day of stellar presentations. If you have access to your agenda, which is available at our webpage, if you go to www.moh.gov.jm and click on the 12th Annual National Health Research Conference, you will see the agenda of activities. And you will note that today we will be focusing on COVID-19 and chronic non-communicable diseases, in addition to a panel discussion on men's health. So we have a lot in store. So at this point in time, I will hand over to our first moderator, who is Mr. Howard Lynch, who is the Director of Policy, Planning and Development at our own Ministry of Health. So welcome, Mr. Lynch.
Okay. Good morning, all.
Good morning.
Right. Howard Lynch, Director of Policy Planning and Development, and I must apologize for the delay in coming on. I had some technical challenges that I had to resolve. Right. So this morning session, the moderator for, and I'd like to extend welcome to all. The second day of this research conference, and I wasn't able to log on fully yesterday, but it must have been a very fruitful day, and we are hoping as well that today will be as fruitful and informative as yesterday. So on behalf of the organizers, Ministry of Health and Wellness, I extend welcome to all those physically there at the Jamaica Pegasus, as well as those persons online. Okay, so before we move into this morning's proceedings, I now invite Ms. Sonia Parchment, Mrs. Parchment, to do the invocation. Mrs. Parchment.
Good morning. Good morning, one and all. It is indeed a pleasure to be here this morning. Let's pray. Almighty God, sovereign God, loving Father and friend, how we worship and adore you this morning. Lord, we can indeed say, this is the day you have made, and we will rejoice and be glad in it. We thank you for the gift of life and the opportunity you have given us to be here today at this 12th Annual National Health Research Conference. Lord, you have been good to us even as we go through this pandemic. Some positive things are happening, and we say thanks. Father God, we pray for our Honorable Minister, our State Minister, Permanent Secretary, Chief Medical Officer, directors, and just about everyone here this morning. We ask that you send your Holy Spirit to be our guide and give us wisdom to understand every topic that will be presented. We pray for each participant that you may bless them. Enlighten our minds and let your presence and love be felt in an unusual way today. May this conference bring success and growth to all team members, and most of all, Lord, may your name be honored and you get all the glory. So again, we thank you as we pray this in Jesus' name. Amen.
Amen. Thank you, Mrs. Parchment. All right. So what I'm going to do now is open the morning's proceedings with the first presentation. And the presentation is, before that though, for questions, please put your questions in the chat, and from there they will be answered. Okay, so the first presentation is on the concurrent polysubstance use in Jamaica, prevalence, risk perception, and associated factors, a secondary analysis of the National Household Survey on Drug Prevalence 2016. Now, the presenter is Dr. Kunal Lalwani. He moved to Jamaica 20 years ago and attended the University of the West Indies, Mona, where he received his MBBS degree in medicine. He's currently working as a senior resident in the Department of Psychiatry at the University Hospital of the West Indies, where he is completing Doctor of Medicine qualification in psychiatry. He has worked in the field of psychiatry for the past 10 years in the parishes of St. Anne, Kingston, and St. Andrew, and has a special interest in substance abuse disorders. So, ladies and gentlemen, let us welcome Dr. Lalwani to make his presentation. Dr. Lalwani, you're on. Hello?
Thank you, sir. Good morning, everyone. First of all, I'd like to give my gratitude to the Secretariat at the National Health Research Conference for inviting me to present today. And also, I'd like to welcome everyone in the virtual space. I hope the presentation I do for you today is something that you find quite useful and you learn something from it. So without further ado, let me begin. So as previously mentioned, my name is Dr. Kunal Lalwani, and I do work at the University Hospital. And my topic today is concurrent polysubstance use in Jamaica, and I'm focusing on prevalence, risk perception, and associated factors. Now, what's important to understand is that within the pre-existent literature, most of the studies that have been done have been conducted on single substance use. In fact, polysubstance use or polydrug use is a relatively new area of focus, and the literature that has been put forward has really just come about recently in the last 20 to 30 years. So what was significant of that literature, however, is that persons who use 2 or more substances have a 3 times increased risk of morbidity and mortality in comparison to individuals who use only 1 substance. As such, this served really as the impetus to pursue this topic in particular. So today, the objectives were to determine the following amongst Jamaicans aged 12 to 65. Firstly, the prevalence of concurrent polysubstance use. Secondly, the risk perception of concurrent polysubstance use, as well as socio-demographic and psychosocial factors associated with concurrent polysubstance use. In addition, age of initiation of singular substances of marijuana, tobacco, and alcohol were also examined to see how that would impact or lead to polysubstance use. So, concurrent polysubstance use, loosely defined, is the use of 2 or more substances over a given period of time. And this study examined marijuana, tobacco, and alcohol in a variety of combinations that would have fit this definition of concurrent polysubstance use. With regards to the prevalence of polysubstance use, there's a paucity of literature. In fact, internationally, a few studies have shown that polysubstance use ranges between 10 and 21%. In one regional study done in Trinidad, it suggested that 10 to 17% of students attending a university there engaged in polysubstance use. But of clear importance, prior to this study that was conducted, there is no data available regarding the prevalence of polysubstance use in Jamaica. Now, risk perception is really an individual's judgment as to how harmful they perceive a drug to be or not to be. And as I had mentioned previously, most of the research that has been conducted regarding risk perception has been done towards single substance use. And worldwide, there are just a few studies that have looked at this topic of risk perception and polysubstance use. And in the context of Jamaica and the Caribbean, there are no studies prior to this that would have looked at this topic. Now, socio-demographic and psychosocial factors are extremely important. In fact, its influence on substance use cannot be underestimated. So within this study, we observed the association between 9 socio-demographic factors and 3 psychosocial factors and its impact on graduating to polysubstance use. Our methodology, well, we did a secondary analysis of the Jamaica National Drug Prevalence Survey of 2016. And that survey, up to this current time, still remains the largest ever survey conducted here in Jamaica. It included almost 5,000 participants from all 14 parishes across Jamaica in its study. Our secondary analysis utilized univariate, bivariate, and multivariate tests to generate our results. Tests such as the Kruskal-Wallis test, Mann-Whitney-U test, Roman sphere correlation, as well as linear regression analysis were our tests that were utilized. And statistical significance was known to be as a p-value of less than 0.05. So what did our results show? Well, in this first slide, you would see that in Jamaica, alcohol was the most prevalent substance of almost 75%, followed by marijuana, tobacco, and that almost 20% of the participants, or the data generalized, were polysubstance users. In addition, our study highlighted that polysubstance use was significantly higher amongst men, persons who were married, and quite interestingly, persons living in the rural areas of Jamaica, as well as persons who were non-Christian. Of significance, individuals between the ages of 18 to 54 that represented the younger demographics were more likely to be a polysubstance user than persons over the age of 55. And individuals who are skilled and unskilled workers were more likely to be polysubstance users than professionals. Now, of essence was that concurrent polysubstance use was significantly associated with easy access to marijuana. And what was very important and critical as well is that persons who initiated using any one of the 3 substances we studied, whether marijuana, tobacco, or alcohol, were well associated with graduating to concurrent polysubstance use. Now, our multivariate analysis did generate some significant risk factors and protective factors. In terms of the protective factors, individuals with moderate to high risk perception of marijuana were shown to be slightly less likely to use 2 or more substances. More interestingly, however, was that unemployed individuals were 2 times less likely to use 2 or more drugs. With regards to the risk factors, individuals with a low age of initiation of marijuana use in particular were slightly more likely to use 2 or more drugs. And of importance and clear significance was that individuals who had family or friends who utilized illicit drugs or drank a lot of alcohol were 4 times more likely to use 2 or more substances. And this graph that I have here is really a forest plot that just highlights the risk factors and the protective factors. As you would see from the graph, the three risk factors that are to the right of the graph were shown to be associated with increased polysubstance use. Now, what does all of our findings really tell us? Well, in summary, 1 in every 5 Jamaicans are polysubstance users. In fact, in Jamaica, the most common combination was alcohol and marijuana, which is a very unique finding given that world over, internationally, the most common combination of 2 substances was actually alcohol and tobacco. What is also important to note is that concurrent polysubstance use was higher when risk perception for marijuana in particular was low. And as I had mentioned previously, in spite of all 3 drugs having some predisposition to leading to polydrug use, marijuana was clearly the one with the most significance after being tested in multivariate analysis. Now, what was very, very telling in our study was that this particular combination, this triple combination of marijuana, tobacco, and alcohol was 17 times higher in our society compared to a comparative study that was done in 6 Latin American countries, our regional neighbors. In fact, in Latin America, the percentage of persons who utilized this particular combination was approximately 2%. In Jamaica, our prevalence of 35% suggested we're using this particular triple combination. And that is important because, as one would have understood, substances, the more you use, the heavier you use, would have clearer, greater implications. Now, what I would love everyone to understand, take-home points. If you remember anything from this presentation, these are the key factors I'd like you to remember. 1, that early marijuana use leads to polysubstance use. In fact, that was the most significant association. And in many other countries worldwide, they have looked at this concept and they have attributed marijuana to being a possible gateway drug. And what that really means is that when youngsters start to utilize marijuana, they were more likely to move on to more severe substances. And those would include other illicit drugs such as cocaine, amphetamines, opioids, etc. So that's a very important point. Also, in our society, it was found that employed persons were the more predominant polysubstance user, which really and truly, historically speaking, it was found that unemployed individuals were more likely to use a multiple set of substances. This represents a sort of a worrying transition if it is that most of our employed force are now engaging in polysubstance use. We suppose that the most likely cause was because there was just more disposable income for people to afford to purchase more than one substance. And of course, if you are able to do that, the risk of heavier use of substances is very likely. Now, of the greatest significance in our study was that persons were more likely to be polysubstance users if family and friends were illicit users. And that is very, very important because it speaks to the peer and the parental influence. As we know, most of the times when persons start using substances is usually within adolescence, a time of experimentation, a time of early influence by peers and friends, and of course looking up to our mentors and family members as role models. And so clearly, if within that phase of time, it has been shown that there's a significant association to graduating to polysubstance use, that can be something that needs to be looked at very, very closely. Now, in conclusion, what this study, I hope, has done, it has filled a knowledge gap. Certainly within Jamaica, it represents the first study of its kind that has looked at this concept of polysubstance use. It has given us some information regarding the prevalence. As I had mentioned, almost 1 in 5 persons in Jamaica are a polysubstance user. And it has given us some indication with regards to risk perception and the associated factors that play a role in person graduating from a single substance to using multiple substances. Of course, it has also created an avenue for us to look at in terms of policy and programs. In Jamaica, most of our policy and programs have been targeted towards persons who are single substance users. You will behoove me, and you would notice on advertisements, on health programs, persons will speak usually of cannabis, or they will speak about cigarette. But what this study has given us an opportunity to do is to incorporate this group of people, polysubstance users, into the messaging regarding health education and promotion. And lastly, but perhaps very most importantly, is the need for comprehensive marijuana intervention programs to be commenced early. And what this study showed us was that, one, that marijuana had the most significant association in graduating to polysubstance use, that there was a low perceptive risk of marijuana use, and that also the age of initiation and easy access were significantly correlated with marijuana use and polysubstance use. So it is perhaps the utmost important that we as a society look at a comprehensive overhaul regarding marijuana use in this country. Now, just 1-2 minutes I'd like to take to acknowledge some of the persons who were very, very instrumental in my research. Professor Wendell Abel, he is my supervisor at the University of Hospital of the West Indies, and he was a great, tremendous source of learning from, a teacher, and he guided me very, very, very patiently in my research. Professor Everard Barton, who has been a massive mentor of mine since I was a medical student, I'm extremely grateful to your guidance. Professor Roger Gibson, who's the head of the Department of Psychiatry at the University Hospital, I want to thank you for giving me the support and the time to actually complete this project. Mrs. Patrice Whitehorn-Smith, I'm sure that name is quite familiar in the academic circles, a brilliant researcher in her own right. She was very, very helpful in conceptualizing my research with me. My colleagues, Dr. Joni Gay McCleary and Dr. Jeffrey Walcott, two very close friends, two psychiatrists as well, whom were very important advisors and soundboard while I was trying to create this presentation. Most importantly, my family, my sister and my parents, who I'm sure are watching from Barbados. I just want to thank you for all the blessings and guidance you've given me in my life. And last but not least, my wife, Shalini, who especially in the last 3 months or 4 months have been so comforting, very supportive, and very loving, and giving me the time to do this project. So at this moment, I'd just like to acknowledge everyone here and tell you thank you once again for allowing me to present this topic. And I really, really hope that something worthwhile, something good will come from what we have discussed, or at least I've presented today. Thank you.
Okay. Thank you, Dr. Mariwani, for that insightful presentation. We're just to advise that the Q&A session is really after all three presentations. And as was advised, the raise hand feature is there for the Q&A and the chat as well. So moving on to the second presentation this morning, which will be oral presentation 9. And it's titled Technology Acceptance of Mobile Health Apps for Patients with Non-Communicable Disease, Patients During the COVID-19 Pandemic. Our presenter is Ms. Janelle Anderson, who's a final year student at the University of Technology, Jamaica. She's pursuing a BSc in computing with a major in information technology. Ms. Anderson, along with 4 other final year students, completed this research as their final year major project under the able supervision of Ms. Susan A. Muir. So, ladies and gentlemen, could you welcome Ms. Janelle Anderson to make her presentation. Thank you. Ms. Anderson, you can go ahead.
Okay, so good morning, everyone.
I'm sorry to cut you, Ms. Anderson. Sorry, I must apologize. You have 15 minutes.
15 minutes. Okay, no problem. So first, let me start off by saying major thank you to the Ministry of Health and Wellness for this opportunity. My teammates and I are indeed very grateful for this opportunity to present our project. Now, as a reminder, the title of our project is Technology Acceptance of Mobile Health Apps for Non-Communicable Disease Patients During the COVID-19 Pandemic. So let's get into it, right? So the coronavirus initially surfaced in Wuhan, China in December 2019 and has since spread at an alarming rate, which has prompted the World Health Organization to declare it as a global pandemic. Now, COVID-19 is an infectious disease that can spread from an infected person's mouth or nose in small liquid particles when they either cough, sneeze, speak, or breathe. Now, according to the CNN dashboard, 2020 COVID tracker, there are approximately 251 million cases of COVID-19 worldwide and approximately 5 million reported deaths. Now, in Jamaica, according to the Ministry of Health and Wellness, there are approximately, as of November 9, 2021, there are approximately 90,000 confirmed cases of COVID-19 on the island and approximately 2,293 deaths. Now, of the persons who died, 73.9% of those were persons aged 60 and above. So now, persons who contract this virus face substantial health concerns, and it has resulted in death in the worst case situations. So individuals who are older in age or who have a pre-existing comorbidity are at a higher risk of catching and succumbing to the COVID-19 virus. And that's according to Jordan et al. 2020. Now, non-communicable disease patients are one such category of people who they have chronic illnesses and it requires them to have a long-term medication for their afflictions. Furthermore, health systems are struggling with the effects of the COVID-19, and governments of numerous nations have established certain measures and tactics in order to control the spread of the virus. Now, these policies have affected the non-communicable disease patients, where they have challenges getting their prescriptions filled as well as sticking to their medication regimen. So looking at our research problem statement, we see that COVID-19 has indeed caused a disruption that has affected NCD patients, which makes them getting access to medical care difficult, as well as we see a decrease in patient turnout. And as a result, there is a difficulty in getting prescriptions filled, which can affect the well-being of these patients. So now, according to Zhang et al. 2020, emerging research shows that these persons who have chronic diseases have a higher rate of succumbing to the virus, meaning that they could possibly die from contracting COVID-19 and should continue to monitor their health carefully. So therefore, there's an opportunity to explore the potential use of a mobile health app as a countermeasure for patient care when prescribing medication for these chronic illnesses. Now, the main objective of our research study was to measure the technology acceptance of the use of a mobile health app with e-prescribing capabilities, as well as monitoring of medication adherence among three particular groups: the non-communicable disease patients and the health professionals, which include both physicians and pharmacists. Taking a look at our research question 1 states that what is the level of technology acceptance of Jamaican physicians, NCD patients, and pharmacists towards adopting e-prescription apps in Jamaica? 2, how receptive are they to monitoring medication adherence online or via a mobile health app? And 3, what are their perceptions of using a pilot version of the mobile health app? In moving on, our research study had both theoretical and practical significance. Theoretical being that there is a lack of literature on mobile health apps and e-prescription apps in Jamaica, and therefore our study could contribute significantly to the existing body of knowledge. Now, if implemented, this mobile health app could provide practical significance, being that it could reduce waiting time for those filling prescriptions, as well as it could improve medication compliance in NCD patients. Now, for our research methods and procedures, a cross-sectional mixed method studies was conducted through the use of survey instruments to gather both qualitative and quantitative data from the Jamaican physicians, pharmacists, and NCD patients. in looking at our population, as of 2017, according to the Jamaican Medical Council, there were approximately 2,236 physicians in Jamaica. We could not ascertain the exact amount of pharmacists that is present in Jamaica. However, there are approximately 495 pharmacies on the island, so it is safe to assume that each pharmacy has at least one pharmacist. Now, according to a study done by the World Health Organization in 2016, approximately 20,000 Jamaicans died in that year, and of those who died, 79% of those deaths were NCD related. Now, for our sampling, we use the convenience sampling for both the quantitative and qualitative aspect of our project, where we had anticipated 100 NCD patients. However, we only got back 83 responses. For the health professionals, we wanted 30 health professionals. However, we only got 16 responses. So for our data collection instruments, we use electronic questionnaires for both the NCD patients and the health professionals, as well as we use semi-structured interviews for the physicians and the pharmacists. Now, our study had 3 major limitations. The first one being that our findings could not be generalized to the entire population due to a relatively small sample size for the health professionals, as well as we used a non-probability sampling technique, that of convenience sampling. Now, due to the cross-sectional design of our study, our study could not confirm the causality and contingent effects of users' level of acceptance before and after they adopt this technology. Now, our third limitation was that due to the self-reporting nature of questionnaires, we could have introduced bias into our study, which can affect generalizability. Now, we had done a mini development of our e-prescription app, of our mobile health app with e-prescription capabilities, as well as that of monitoring medication adherence. Now, on the left, we see that we had 3 participant groups, the pharmacists, the physicians, and the patients. On the right, it shows the registration form for a physician that they should fill out in order to get access to the app. Now, there were certain functionalities awarded to the physician, where on the left, they had the ability to chat with patients, where they could conduct their routine checkups with them. They could view all their patients that they had on their roster. For their profile, they could look at patient history as well as their medication regimen. Now, for patients, they had the ability to set medication reminders, view prescription, and have live chats with their physicians and pharmacists, as well as to make payment for their prescriptions. Now, when a patient sets a reminder, they are required to enter the name of their medication, as well as they can select the amount of days that they're supposed to take that medication, as well as they can set an alarm. They can set an alarm to remind them to take their medication. So when it is time for them to take a particular medication, an alarm is sent out to them where they can either accept or decline this. It was in our intention that when they decline this request, the app would continually give them reminders until they are proven that they have that they have indeed taken the medication. Now, for the pharmacists, they were able to view prescription as well as have live chat, with patients. Moving on to our results and findings. For NCD demographics now, we had 83 respondents for our questionnaire. So 60% were females, while 40% were males. Now, in terms of the age of the patients, we see that the 18 to 29 category had the highest number of respondents. This is atypical of the Jamaican society, as we normally see that older persons tend to have more chronic illnesses than the younger generation, and that is according to a report done by Statin in 2020. So moving on, figure 3 shows that the demographics for the health professionals were 50% were females and 50% were males. So in looking at the overall acceptance for the patients, 60% of patients were agreeable to adopting e-prescription app. And we also did a correlation for the dependent variables acceptance and the independent variables performance expectancy, effort expectancy, facilitating conditions, and social influence. So what we find is that all of the independent variables had positive correlations. However, effort expectancy, facilitating conditions, social influence had a positive correlation, while performance expectancy had a moderate correlation. Now, the data is highly significant as their p-values are less than 0.01. So that indicates to us that we can have a 99% confidence in the data being displayed and that the correlation does in fact exist. Now, figure 5 shows the health professionals' overall acceptance, where 63% of them, 12 out of the 16 respondents, indicated that they would be willing to adopt e-prescription apps. Table 2, unlike for the NCD patients, the health professionals stated their data shows that only performance expectancy and social influence had any significant data, where they had positive correlations and their p-values were less than 0.01. So again, we can have a 99% confidence that the correlation does in fact exist among the variables. Now, table 3 shows how willing persons are how willing they are to use the mobile health app to monitor medication adherence, where overall 70% of respondents indicated that they will be willing to use the app. And of those who were willing, we saw that the younger age persons were more receptive to using the app, where they account for 79%, while those above 60 accounted for 43%. In looking at table 4, now we see that those who are more willing were tertiary level individuals as well as those secondary level graduates. So I look at our interviews. Health professionals indicated that they faced various challenges when using a pilot version of the mobile health app, where they quoted that functionality, validity, and security were certain concerns that they had of the pilot version. They, however, saw potential benefits of this app, where they say that improved medication compliance and individualized personal care could be significant in the future if this application was implemented. So this slide just basically shows the quotations from physicians that were interviewed, where physician C said, and I quote, "I actually believe that if properly implemented, it could possibly improve medical management in the hospital setting." For the patients, in terms of their perception towards the mobile health app, their main desired security features were remote data wipe, encryption of data, as well as easy to understand user policy. So in conclusion, the factors that influence the adoption of NCD patients towards adopting e-prescription apps were effort expectancy, facilitating conditions, social influence, and performance expectancy. Those factors that influence the health professionals' decision were social influence and performance expectancy. Now, majority of the NCD patients were willing to monitor medication adherence via the mobile health app. However, we found that the more willing participants were tertiary level graduates as well as those below age 50. And again, the health professionals saw perceived benefits of using a pilot version, which were improved compliance to drug regimen, as well as it could be convenient for the NCD patients. The patients saw various challenges such as lack of functionality, security issues, as well as validity issues as well. So recommendations for practice. App designers should focus on ease of use and in terms of functionality and graphical user interface, since effort expectancy was the highest contributing factor for NCD patients. Also, we recommend that government provide the necessary or improve on the necessary infrastructure to support the technology by ensuring that there is availability of the internet. For future research, we recommend that replication of this study could be done in rural areas with a larger sample size for the health professionals. Also, we recommend that longitudinal study be conducted to compare the acceptance levels with the actual use of the app. As our study, we only focused on the intent to use and not the actual use of the app. So here are my references, and this concludes my presentation. So thank you all for listening.
Okay, insightful. So thank you, Ms. Anderson, for that presentation. And as I'll remind, the Q&A, raise hand, and we will take questions after the third presentation. So segueing into that, the third presentation for this morning, which is presentation number 10, and it's titled Trends and Factors Associated with Initiation of HIV Treatment and Uptake of Viral Load Testing among PL-HIV in Jamaica, as persons living with HIV in Jamaica. The presenter for this paper is Ms. Anya Kushney. She's a final year doctoral candidate studying epidemiology and public health at, and I'm going to say this is it Tampere? The pronunciation may be off, University in Finland. I don't know Finnish. So she has over 10 years of experience in public health research and program management, primarily with Jamaica's National HIV Program. She's currently a public health analyst for the USAID Global Health Supply Chain Program. So, ladies and gentlemen, please help me to welcome Ms. Kushney as she makes her presentation. Ms. Kushney, over to you.
Good morning. Good morning, Mr. Lynch, and good morning, everyone. It's Tampere University.
Oh, it's Tampere.
Yes.
Next time I'll get it. Tampere.
Sure.
The little fish I've now learned.
Okay. Okay. Good morning, everyone. I'm Anya Kushney, and thank you for having me. My study this morning is trends and factors associated with the initiation of HIV treatment and uptake of viral load testing among PL-HIV in Jamaica. And this is our outline. We'll be looking at study rationale, research objectives, methods, results, and conclusions and recommendations. Okay, so as at the end of 2019, Jamaica had achieved 44% ART retention and 35% virologic suppression among persons on HIV treatment. We were significantly lagging behind in the global targets. The UNAIDS global targets, which we have signed on to, ask that we achieve 90% ART retention and 90% virologic suppression among persons on ARV treatment by 2020. Jamaica was not able to achieve that goal. So as a result, the Ministry of Health has earmarked the year 2025 for achievement of these 90% targets. For this to occur, an analysis of the factors associated with ART and viral load uptake was recommended in the current National HIV Strategic Plan. And this is where our study comes into play. The study aims to describe PL-HIV who access HIV treatment and viral load testing, as well as assess the factors associated with immediate ART initiation and the uptake of viral load testing. Why do we focus on immediate ART initiation? Well, it is one of the key objectives in the current national clinical guidelines. We also know the benefits of immediate ART initiation, such as improved ART uptake. Despite the government of Jamaica providing public access to ART since 2004, we still lack or are lagging. We're getting persons on treatment and keeping them on treatment. Also, immediate ART initiation is associated with increased retention in care, higher rates of viral suppression, and reduced risk of morbidity and mortality. With regards to viral load testing among ARV patients is the best predictor of treatment outcomes, and it is a standard that is currently recommended by WHO for clinical management of HIV patients. So we carried out a secondary analysis for data that was extracted from the National HIV Treatment Service Information System, or TSIS-2. TSIS-2 is a case-based database that collects both clinical and demographic patient data. It collects over 100 variables. We assess 8 routinely collected variables, specifically gender, age at ARV initiation, regional health authority the patient was assigned to, the first clinic date, first ARV date, first CD4 cell count, first viral load testing date, and the first viral load results. Our sample consisted of over 8,000 persons between ages from 15 years and older who initiated HIV treatment between January 2015 and December 2019. So our study spans 5 years. Ethical approval was given by the Ministry of Health. For our data analysis, we conducted a bivariate analysis initially to look at 2 variables. Time to ART initiation, which was based on the difference between the first clinic date and the ART initiation date, as well as time to first viral load testing, looking at the duration between the first viral load test date and ART initiation date. ART initiation date was categorized into 6 categories: preclinical, same day, 1 to 7 days, 8 to 21 days, 20 to 30 days, or over 31 days. And viral load testing, we had 4 categories: pre-ART, 0 to 6 months, 7 to 12 months, or over 13 months. We also conducted a multivariable logistic regression where these 2 outcomes, ART initiation time and uptake of viral load testing, were made into binary variables. So we were looking at the significant association with regards to same day initiation or versus 31 days, or with regards to uptake of viral load testing, no viral load test, or did the person have a viral load test? We conducted our data analysis in our program, and we reported adjusted odds ratios and confidence intervals. So with regards to our results, we found that mostly females were on treatment. Also, persons who were on treatment were mainly 20 to 39 years old and located in the Southeast Region Health Authority. Most persons were also diagnosed at an early HIV stage, and the median time to ART initiation was 14 days. Persons also initiated ART at either 31 days after the first clinic date or the same day as the clinic date. So we looked at same day ART initiation closer, and we found that there was a 72% increase over 5 years with ART initiation. This chart shows that initiation based on the proportion of PLHIV that initiated treatment in that specific year. For persons with same-day ART initiation, there was no difference between genders or HIV clinical stage of diagnosis. Most persons were 20 to 39 years old and had achieved viral suppression at the first viral load test. With HIV viral load testing, this flow chart shows viral load testing uptake among the sample. We start with the entire cohort. We found that for those who were eligible for testing based on the national guidelines, 90% of those who were eligible for testing actually had a first viral load test documented. Of those who had a first viral load test documented, 79% had a second viral load test documented. So we go from 90% to 79%. Only 10% of those who were eligible for the first viral load test did not have a viral load test documented. And 21% of those with a first viral load test did not have a second viral load test. With our regression analysis. So our first regression analysis looked at ART uptake, and the binary variables here were 31 days versus same day ART initiation. We found that males were significantly more likely to not have a first viral load test compared to females. We also found that persons in the Western Health region were significantly more likely to not have a viral load test compared to persons in SERA. And also, persons who are 40 years or older were more likely to have a viral load test compared to persons who are 20 to 39 years old. Those who were suppressed, those persons who were virally suppressed, were also significantly more likely to have had, or significantly more likely to have had a same day ART initiation. Oh, I'm sorry, I was saying the wrong thing. Right, so males were, let me start that again, I'm sorry about that. The males were significantly more likely to have had same day ART initiation, and persons in Western region more likely to have had same day ART initiation compared to those in SERA. Persons who are 40 plus years were also significantly more likely to have had same day ART initiation, as well as those who were virally suppressed. For viral load testing uptake, we found that males were significantly more likely to have no viral load test. This is also the same for persons in Western Region Health Authority. And persons who were 40 years or older were more likely to have a viral load test, as well as those in Southern Region and NERA. Late diagnosis was also associated with viral load, with significantly more likely to have had a viral load test. So in conclusion, Jamaica, what we found is Jamaica is increasingly achieving same day ART initiation. We found that 72% increase over the 5-year study period. Persons with same day initiation had achieved viral suppression at the first viral load test. We did find a gender disparity. There are more females on treatment overall, but males were more likely to have had same day ART initiation, but less likely to have a viral load test, which means we have issues retaining men in care. Coverage of the first viral load test was strong. So we have adapted routine viral load testing, but retention is lacking as the coverage declined with the second viral load test to 79%. First viral load test is received 0 to 6 months after initiating treatment. And this is consistent with the current national treatment guidelines. Coverage of baseline testing, this is testing before ART initiation. We found that this was at 28%, despite the national guidelines stipulating that viral load testing should be done after treatment initiation. There are some clinicians that still prefer to have a baseline viral load test. So there are some clinicians that are still testing, even though patients have not yet initiated ART. So our recommendations, we recommend a qualitative assessment to understand what are the challenges in accessing and implementing routine viral load testing, particularly among males. Why are males not showing up for viral load testing even though they are being started on ARTs? Regular assessment of patients with missing viral load testing records. We notice a significant number of the records were missing from TSIS. Why is this happening, and who are these patients? We also think there is a need to improve routine laboratory data management to address the occurrence of missing clinical data. Whenever a patient does not show up, or whenever a patient's records are not documented, what is done about this? Is the test result actually available and not in the database? And how is this being managed? We also recommend exploring the effects of the supply chain performance on patient outcomes, particularly ART and viral load testing uptake. Whenever a patient does not show up for treatment or for health services in general, we tend to assume it's the negligence of that patient. But we very rarely look at the systems challenges that we're having. And the persons who are involved with patient management are very rarely also involved in supply chain management. And that data is rarely triangulated to see how the supply chain management has affected patient outcomes. And so this is a recommendation that we'd like to make going forward, particularly within the midst of the pandemic. We know we're in a supply chain crisis right now because of the pandemic. And we do think that this would be a useful data analysis to look at our treatment outcomes more robustly. So our study strengths and limitations, we had a large sample with all 4 health regions represented. Our data quality, we noticed missing data or non-entry of data, which could be responsible for persons not having a documented viral load test and not necessarily non-uptake of testing services. Our C statistic for our regression analysis produced fairly strong models with 62% accuracy for viral load testing uptake and 60% accuracy for ART initiation. The C statistic gives you an idea of the strength of your model, and anything above 50% is considered a strong model. The data did not allow us to measure the time retained on ART, time retained in care, or assess virologic failure or deaths, because those are usually removed from thesis. Thank you, everyone, and I've come to the end of my presentation. Thank you for listening, and I'd just like to acknowledge my advisory panel and also the Ministry of Health's HIV Strategic Information Unit for providing the baseline data.
Okay, thank you, Ms. Kushney, for that presentation. And I should have indicated to the group that this is the scientific session 3, and it's titled COVID-19 and Chronic Non-Communicable Diseases. Now, ladies and gentlemen, just a reminder for the general participants, you can put your questions in the Q&A, and comments in the chat. Now, for the judges, I don't know if any one of the judges have a question. Let me check.
Yes. Good morning, Mr. Lynch.
That's Ms. Huntley, Mrs. Huntley Jones.
Mrs. Huntley Jones.
Yes.
Yes. Good morning.
Morning.
Good morning to the presenters and to the participants online and at the hub. Thank the presenters for their presentation. All right, so I have 2 questions, one to Ms. Anderson and one to Ms. Kushney. Again, very good presentation. So to Ms. Anderson, could you remind us what were your findings as a possible uptake of the use of your app with the older age group? I think you said that it might be low, and then what could be done to mitigate against it, since they would be a target group that we would want to focus on. And then my question to Ms. Kushney, will be to, let me get a response from Ms. Anderson, then I'll give my question to Ms. Kushney. Thank you, Ms.
Okay, so that's a very good question. In my presentation, I stated that those persons who were under age 60, they were more willing to actually accept the use of the app and to actually adopt it. But for the older persons, I would suggest that we do conduct another study to find out what are the barriers that influence or that deter them from actually wanting to use a mobile health app for those particular reasons, in order to monitor their health and to fill their prescriptions. So I would say that another research study could be done to find out the barriers, and then we can go from there and say, all right, what can we do to actually solve those barriers to allow them to actually use the app.
Okay.
All right. Thank you, Ms. Anderson. And if I may, Mr. Lynch, to
Yes.
Ms. Cushney, I found it quite interesting regarding the data being missing from the laboratory assessment. And from your study, what were some of the systemic issues? Because there seem to be some systemic issues that you might have found that the ministry would need to consider as we look towards strengthening our data management and this whole matter of care tree. So what systemic issues you would have identified, and what would be your recommendation to show that data management? Thank you.
Right. So one of the issues that keeps coming up with regards to suboptimal viral load testing in Jamaica is our laboratory-based challenges, whether it's the data not being able to be uploaded to TSIS on time, or whether or not the treatment sites have someone who is a dedicated person who is able to enter that data into the treatment database. That's a challenge. So we do still very much have a paper-based system at our treatment site. So the viral load testing is done and it's entered into a logbook at the treatment site. And that data doesn't always make it into TSIS in an on-time basis. And so we are still using a paper-based system to manage our patients, mainly with regards to viral load testing. It's something the Ministry of Health is working on and has been working on, making sure that the viral load testing results from the lab is being uploaded to TSIS in a routine fashion and on time enough for them to be able to make certain clinical decisions around patient management. So that's something that's been coming up. It's detailed, documented in the National Strategic Plan. Especially within COVID, our viral load testing coverage did decline at the beginning of the pandemic. And that, of course, is because there were so many issues around treatment sites being closed and, just not having people available to actually get the data from the lab and put it into TSIS. So there is that system issue that we need to address.
All right. Thank you so very much. Over to you, Mr. Lynch.
Thank you.
Hi, Mr. Lynch.
Yep, I was coming. I was coming.
Okay.
I'm guessing that is Mrs. Royal. Is it Thomas?
Yes, you have guessed correctly.
So you're up next, and then Dr. P. I won't chance to pronounce the last name. Dr. P will help us when they come on. Go ahead with your question.
Okay, sure. Very good job to all the presenters in this session. I thoroughly enjoyed your presentations. I have two questions. One for Ms. Janelle Anderson. Ms. Janelle Anderson, your presentation was very good. You made note that you did a convenient sampling, and I wanted to know, although you mentioned things, I wanted to know if there were any other sampling methods that you could have employed for your study.
Well, we wanted to use the simple random sampling that was a probability sampling technique that we had looked at in order to gather the physicians and the pharmacists. However, when we started it, we find that it was difficult to actually get persons to participate. So we had to switch to the convenient sampling so that we could get those more convenient to us in order for us to complete the study. So, yeah.
Okay, thank you. And my next question is to really Dr. Kunal Lalwani. Can I ask him a question?
Of
Is
course
he
you can
on?
ask him.
Okay then. Very interesting presentation also. What would be any of the applications or recommendations that you would have for persons, especially during this COVID-19 pandemic, in regards to concurrent polysubstance use?
Okay, thank you for that question.
Dr. Lalwani?
Are you able to hear me?
Yeah, you seem to be muted.
Okay, good. Thank you. So,
I see you talking, but we're not hearing.
Sorry. So the significant finding that we did notice with regards to polysubstance use was definitely affiliated with marijuana.
Sorry, Dr. Lalwani is muted. Yeah.
Yes?
Dr. Lalwani?
Yes?
Maybe something is wrong with his microphone.
Microphone is on.
Because he has to go all over that, what he has said before, because he was answering and nothing was coming through.
Use this one.
You soon get the answer.
Okay, thank you.
I'm wondering, Dr. Lalwani, you're ready now?
Yes, I'm here. Can you hear me?
I was wondering if I could move to Dr. P's question if it's not for Dr. Lalwani and then get back to him. I think that's what we do. Dr. P?
Yes, sir. Good morning.
Morning.
Thank you.
Help me with the surname now, please.
Along, just along with E. Along.
Along, I've heard it before. Okay, go ahead, doctor. I hope it's not for Dr. Lalwani, your question, isn't it?
For Dr. Lalwani and Anderson and Cushing.
But start with Ms. Cushing and Ms. Anderson first while they sort out Dr. Lalwani.
Okay, thank you. Thank you all for your wonderful presentations. I must commend you. Excellent work done. While I was listening to Ms. Cushing with the chat, the data that was utilized. The data that was utilized for this research, would it have included some of the the issue that we find in our nation so rampantly, the young men, the rate of crime and violence? Could this be something that you could say this substance, polysubstance use would have been responsible, or do we need to also do some analysis on those who are involved in crime and violence.
Sorry, have we resolved Dr. Lalwane's mic? Because he has a pending question plus this new question. Anybody can help us at center? Well, it seems that there may be a challenge getting a response from Dr. Lalwane. There may be some technical issues at the site. So let us move on. Those questions are pending.
Okay, thank you.
Maybe at another time, you'll get the answers. All right. What there are some questions here. Is that Kaushal Singh is asking for viral load and acceptance were difference among sites considered in the analysis. For example, hospital-based sites versus health center-based sites. Ms. Kushney, you have an answer for that one?
Right. So in terms of the site breakdown, no, we didn't look at the different sites. We didn't want to discriminate against in the analysis, so we didn't do that.
Another one for you. Are these, this is from Gillian Campbell, are there specific units assigned in each region for the management of these patients?
Which patients?
Well, she didn't say.
I'm not clear. The question isn't clear.
Right, because it says, are there specific units assigned in each region for the management of these patients? Okay, let's move on.
Doctor, it could be the same patient you are dealing with, your subjects.
Okay.
The HIV patients?
Yes.
Yeah, yes, there are treatment sites assigned all across the country. I think we have 38 treatment sites across Jamaica at the moment.
All right. Okay, she clarified it, HIV patients.
Yes.
Right.
Yes.
And the other question again from Kaushal Singh, do you think gender variation is due to difference in general health-seeking behavior between male and
female? Mr. Mead, just tell her that we're coming, or the road is rough.
Mrs. Huntley-Jones? Mrs. Huntley-Jones? Okay.
Yes, Mr. Lynch?
Boy, your conversation just messed up our question, you know.
You heard this, I'm so sorry.
The whole world heard it. Sorry. Okay, back to the question from Kaushal Singh. Do you think, this is for you, Ms. Kushney, do you think gender variation is due to difference in general health-seeking behavior between male and female?
Yes, absolutely. So what we're seeing in Jamaica is not unique to Jamaica. It happens across the world, and it's usually accounted to the poor health-seeking behavior that we see among males. Yes.
Okay. That seemed to be, let me go back to our judges. If there are any other question, if there are any other hand up. Oh, there's some more questions in there. Oh, it's the same questions. Okay. I don't see any further questions or any hand from the Dr. Alonga, you have another question?
Can you hear me now?
Yes, sir. I for Miss Kushney.
Okay.
I wanted to ask her, based on the fact that we know that these are from many researches and your research, that the behavior of men towards healthcare. So what are the ways for us to resolve these?
I have no idea. It's been a nuance for the national program, and I don't think it's specific to HIV.
That's what I know. Oh.
Right. It's just health in general. Getting men to show up when they're not sick, or when they do need follow-up care. It's difficult.
Do we start from the primary school? Do we start to make a jingle about it? Do we start to teach? Because there's nothing teaching cannot make adjustments to. So yeah. Cultural education could assist.
Right, but as I said, it's also not specific to Jamaica, so I don't know if it's cultural or if it's a
Yes, can you hear me? Okay. To be quite honest, I didn't get the full question. We are having some issues here, but I did get the impression that I was being asked about the impact of violence and crime and polysubstance use. Am I right? Okay. So the thing is that with polysubstance use, there have been quite a few studies, at least internationally, that have suggested that persons who are heavy drug users are more likely to engage in crime and violence. And one of the rationale behind that was that in order to support their habits, that was a part of their way of acquiring the means to be able to afford. I suppose also another way to look at it is that what about those individuals who are already in the criminal system? And the truth of the matter is that persons with a polysubstance or a substance use disorder are considered to have some level of mental health disposition. And it is not far from the fact that within the penitentiary systems or within the prisons that mentally ill persons with mental health and substance use disorders are quite prevalent. So I believe that in terms of addressing substance use within the marginalized areas, you would have to conduct your research, but more importantly, think more broad in terms of your interventions. It is that within the prison system, you're thinking about your messages, your health education with respect to promotion, for example, activities that can engage prisoners with respect to substance use or mental health issues, or even interventions. I don't believe right now, whenever someone has a problem with substance in in the system has an access within their confines to at least an acute detox or a long-term rehabilitation system, and that's certainly something that can be looked at. I do know also in Jamaica that when you think about persons who have a polysubstance use and they haven't actually reached the prison system yet, they have created the drug court to sort of mediate that issue. So if you're going to think about drug use, polysubstance use, and its impact on crime and violence, you have to be able to appreciate it from both the individual and the societal, as well as the prison reform. I hope that kind of gives a general idea of answer to the question. Okay, that's a very good question, and you know, this actually did cross my mind about a week ago. I think I was reading in the news that one of our local rum producing and distributor companies reported that they had a profit of almost $9 billion within this same time period, and it started to make me think of, well, in spite of whatever constraints, financial, etc., people are still able to afford or still pursuing substance use. And, well, as we had mentioned before, all of these substances have some predisposition to polydrug use. So in terms of the recommendations, you'd have to consider it within the COVID sense from an individual point of view, such as self-care. As you know, most of us during this year or 2 years would have been within some confines of isolation at home with the lockdown, the quarantine, high risk of substance use, clearly either as a time pass or in response to some mental health issues such as anxiety and depression. Those things would have occurred. So one of the tenets from at least the mental health professional viewpoint is to encourage self-care, encourage social interaction. I know we're doing this presentation right now via Zoom, which is one of the ways that we have had to accommodate in terms of maintaining our social interactions with friends and family. So in terms of the self, that would be one of the strategies. In terms of persons who are still employed, as I mentioned in the study, we found that, and it was quite interesting, that persons who were employed were the higher polysubstance users, and what was surprising is that they were still able to maintain their job despite their drug use. And certainly that can have quite a slippery slope, isn't it? With impact both to the individual as well as the company for whom they work for. So in terms of productivity and costs and healthcare costs, financial embarrassment to individual, I think one of the clear recommendations to these companies would be to engage in some employment or employee assistance programs that can facilitate either help, you know, drug reduction strategies, etc. But that is one way to look at it from those persons who are still employed. And very importantly now, let's just look at perhaps what happens in the home. You know, the study did suggest that the most significant was that what occurs with family and friends using substances and its impact on individuals. And clearly in the last year and a half or 2 years, the persons who we've been most closest to are family and friends. And so the risk of polysubstance use definitely would have been higher. One of the clear recommendations for something like that is, well, reaching out for help, whether it is counseling services at your church or within your community, the mental health services within your community for psychological guidance or care. I do happen to know that certainly in other countries, what has worked very well for polysubstance use is family therapy and family interventions, not just for the adolescent or the person engaging in polydrug use, but the family as a total unit who engages in the same behavior. So I've tried to give you at least 3 different recommendations based on some of our high-risk groups, and I hope that was helpful.
Mr. Lynch? Mr. Lynch?
That's the familiar voice?
Yes, that is the familiar voice. How are you? Yes, sir. And I just want to, I do not have a question at this time because all my questions were somehow answered by the presenters in their presentations. So I just want to concur with the team that thank you so much, all 3 presenters, for your presentations. Over to you now, Mr. Lynch.
Thank you, Mrs. Nelson. All right, so my time moderating the session has come to an end. So I'd like to thank the presenters and thank the participants, and also to thank the persons who have asked some insightful questions and solicited the appropriate response. So, as I say, master control, I'm handing back over to you, and I wish you all, for the rest of the conference, a very good conference. Thank you.
So good morning again, everyone. We want to thank our moderator, Mr. Howard Lynch, for taking us through our scientific session, the first session for this morning, and for the excellent presentations as well as the questions that were generated. And this is what we really do want for our health research conference in terms of raising pertinent questions that will inform policy and practice. At this time, we have a 5-minute break before we segue into our second session, which will be moderated by Dr. Michelle Hamilton of the National Laboratory Services. So we will break for 5. Thank you. Good morning again, everyone. Welcome back. We do apologize for the technical challenges, but we hope that you will be able to log on and continue today's wealth of information in terms of the presentations that we have had. So we just had a very rich session, and we are going to start our next session, which looks at laboratory testing. And this session is going to be moderated by Dr. Michelle Hamilton, who is the Director of National Laboratory Services. And so at this time, I'm going to hand over to Dr. Michelle Hamilton. Good morning, Dr. Hamilton.
Recording in progress.
Good morning. We've been having a wonderful conference so far.
Recording stopped.
Okay, good morning, everyone. I hope you are not. Morning. Good morning, everyone. I trust you are able to hear me. We have been having a wonderful conference so far, and I know that this session is going to be equally as wonderful. The lab is very near and dear to my heart, as you may imagine, but it's not just a personal bias. We are aware that laboratory data plays a significant role in informing public health decision making. And so as we listen to the research about how the results of these research projects can be utilized to improve the health status, not just in Jamaica and elsewhere. So our first presenter is Mr. Simoy Noble, and he holds a BSc in microbiology and is enrolled in the MPhil microbiology program, so Master of Philosophy microbiology program at the University Hospital of the West Indies. His current research focus is on
the molecular surveillance of zoonotic parasites and arboviruses. He was the recipient of the Canada CARICOM Global Infectious. We have a budding scientist here, and so I'm asking Mr. Noble now to make his presentation on the Surrey University Hospital of the West Indies. So Mr. Noble, would you please make your presentation now? Thank you.
Are you seeing my presentation?
Yes, we are. Perhaps you might want to put it on slideshow.
It is on slideshow for me. Are you seeing it now? It's better?
There we are.
So it's good, okay. Good morning, everyone. Thanks for having me. My name is Simon Noble, and today I'll be presenting on a short communication titled The Surveillance of Cryptosporidium Species from the University Hospital of the West Indies. My chief supervisor is Mr. John Lindo. Co-investigators are Dr. Corinne Ong, Dr. Tamara Thompson, and Dr. Amanda Morris. So Cryptosporidium is an enteric protozoan parasite which has a wide host range, infecting animals and humans. In 1907, it was first discovered by Ernest Taizo while conducting histological examination of mouse intestine. This parasite has been reported in humans in 1976, and it was first reported in an immunocompetent child who was suffering from acute enterocolitis. And this was followed by the identification of this parasite in an immunosuppressed adult. This parasite is recognized globally in the 1980s and 1990s as a disease or pathogen of AIDS patients, and it is common among outbreaks among veterinary students, seeing that the parasite has a reservoir host, which is the cattle, and veterinary students are normally in close contact with these animals. According to the Global Enteric Multicenter study, it identified Cryptosporidium as the second leading cause of diarrhea in children under 5 years of age. This is only surpassed by rotavirus. So this parasite belongs to the family Acomplexia, the order Eucoccidae, the family Cryptosporidiae. There are currently over 40 recognized species and over 70 genotypes of uncertain taxonomic status. This parasite is considered a atypical coccidian because it's resistant to anticoccidial drugs. So Cryptosporidium is a major cause of diarrheal disease in humans worldwide, accounting for 20% of all cases of childhood diarrhea in developing countries. It is associated with poor cognitive function and fail to thrive in early childhood infections. And it has a 10.9% global prevalence in HIV patients. Where immunocompetent individuals are concerned, in developed countries it has a 5%, whereas in developed there is a 7%. As mentioned before, it is of veterinary relevance as it results in clinical morbidity and mortality, and is associated with production loss, which is seen in the loss of weight in young stocks and reduced milk production in cows. So this parasite is transmitted through the fecal-oral route following direct or indirect contact with the infective stage called oocyst. You have person-to-person transmission, which is also called the anthropoonotic cycle. This transmission pathway is seen most frequently in developing countries. Also, you have the zoonotic infection where it is transferred from animals to humans, waterborne transmission, which is frequently seen in developed nations and foodborne transmission. Here's the life cycle of the parasite. We'll be focusing on the small intestine where the oocyst is ingested. Upon ingestion, the spores of the oocyst releases 4 sporozoids, which lodge into the epithelial cells and develop into a tropozoid. The tropozoid first undergo a asexual cycle, followed by a sexual cycle. After the sexual cycle, the parasite then differentiates into a microgament and a macrogament. And following fertilization, it forms a zygote. Zygote can then differentiate into a thick wall oocyst, which is excreted in the feces, or a thin wall oocyst, which can cause autoinfection. So symptoms develop within 2 to 10 days after exposure. The parasite invades intracellular but extracytoplasmic lining of the microvilli, and it causes destruction of these microvilli and epithelial cells. This results in reduced absorption and enhanced secretion, resulting in diarrhea. Other symptoms that may accompany cryptosporidiosis are abdominal cramps, nausea, vomiting, or fever. Symptoms may resolve in 1 to 2 weeks within immunocompetent individuals, whereas in the immunocompromised, symptoms may become chronic. For diagnosis, stool microscopy is the gold standard. This method can be, the sensitivity of this method can be improved by using formalin ether concentration technique, and the specificity can be improved by using a modified Ziel-Neisel stain. Other methods that can be used for detection are PCR testing and antigen testing. These 2 methods are highly sensitive, with PCR being able to genotype different species, which are important for outbreaks and epidemiological investigation. Antigen testing involves ELISA, detecting the monoclonal antibody against the oocyst wall antigen, which have a high sensitivity. And a benefit of this method is that it can be used on both fecal and tissue specimens. So treatment includes the use of nitazoxanide, which is the only approved drug by the FDA, and it is moderately effective in immunocompetent patients. The reconstitution of the immune system with active antiretroviral therapy is recommended for AIDS patients, and for the immunosuppressed, supported therapy and immunotherapy, which increases immune response, is recommended. So the study rationale. So current diagnostic tests lacks sensitivity and lack the abilities to 1, source tract infection, identify genetic diversity, and identify transmission dynamics. Therefore, this study would highlight the power of molecular tools in surveillance and update the knowledge of this parasite in the population. The study aims to describe Cryptosporidium subtypes among patient samples sent in for routine ovine parasite diagnosis at the University Hospital of the West Indies and to understand the transmission patterns. Objective? The sole objective is to identify Cryptosporidium species and subtypes from patients samples using molecular tools such as PCR and sequencing. On to methodology. So ethical approval for this project was granted by the University of the West Indies Ethics Committee. Fecal sample, totaling 500 sent in to the University Hospital of the West Indies Microbiology Department for ovine parasite examinations from January 2016 to March 2018 were collected. Samples were stored at 4 degrees Celsius without preservatives. And here we'll be looking at a schematic of the methodology. First sample concentration was done. This was done using a modified version of the formalin ether sedimentation technique. As you know, formalin is a downstream inhibitor of PCR. So instead of using formalin, PBS phosphate buffer solution was used. For DNA extraction, the sediments that were obtained from the concentration procedure were subjected to 5 freeze-thaw cycles at -70 degrees and 70 degrees Celsius for 15 minutes, respectively. And extraction was then completed using the QIAGEN DNA spool mini kit. For screening and amplification, the 18S nested PCR was done. And for species identification, the 18S restriction fragment length polymorphism PCR was done. The analyte used for this method was the secondary product from the nested PCR. So if C. hominis or C. parvum were obtained from the species identification, GP60 nested PCR would have been conducted to amplify the DNA, followed by GP60 DNA sequencing of the secondary GP60 product. GP60 is basically stands for the 60 kilodalton glycoprotein, which is a genetic marker, which is used for source tracking infection and identifying diversity, genetic diversity within this parasite. If other species were identified from the restriction fragment length, polymorphism PCR, 18S RNA sequencing would have been done. The reason for this is that the GP60 primers are only available for C. hominis and C. parvum, hence we were not able to conduct it for the other species. On the results. So PCR amplification identified Cryptosporidium DNA in 6 of the 500 samples, a 1.2% of all samples tested. C. hominis, Cryptosporidium hominis, was the dominant species identified, N equals 5, and C. ducis marci, a single species of C. ducis marci, was identified. For the C. hominis subtype family IB was the only family identified, and the subtype in that family was IBA10G2. As mentioned before, there are no available GP60 subtype for C. ducis marci species, so we were not able to ascertain the subtype family information. For the discussion, C. hominis was a dominant subtype identified in human samples, which is suggestive that the anthroponotic cycle was the main cause of transmission within the sample group. This finding is similar to a previous study conducted among HIV patients in Jamaica, where C. hominis was the predominant species isolated. C. hominis subtype IB10G2 was the only subtype identified, and this subtype is transmitted between humans and is the only C. hominis subtype identified in countries in Europe and Australia. C. ducis marci was also isolated from a single patient. This species is host-adapted to tortoises and reptiles. To our knowledge, this is the first reported study to identify this species in patients. This finding draws concern to the zoonotic ability of different Cryptosporidium species to potentially cause human infection. Some of the limitations that were faced, only one stool sample was tested. Ideally, for Cryptosporidium, it is recommended that 3 consecutive stool samples on 3 different days are collected. However, we only had access to 1 stool sample. The University Hospital of the West Indies sample represented a small portion of the population, therefore subtype distribution and transmission dynamics cannot be generalized. Additional diarrheal pathogens were not screened, such as rotavirus, E. coli, and salmonella. Factors that may have resulted in low prevalence are underreporting of diarrheal diseases, routine Cryptosporidium tests are not requested, and asymptomatic shedding of the oocysts. To conclude, the results suggested that human infections from the sample population were primarily driven by the anthroponotic transmission of C. hominis. The finding identifies Cryptosporidium ducis marci as a potential zoonotic species, and this study highlights the importance of routine surveillance of Cryptosporidium in the population to better understand the transmission patterns. Here are a list of my references. I'd like to thank God for giving us strength to complete this part of this research. Professor John Lindo, the Department of Microbiology, Department of Basic Medical Sciences, Dr. Tamara Tamsu, Dr. Corinne Ong, and Dr. Amanda Morris. Thank you.
Okay, thank you so much, Mr. Noble, for that very interesting presentation. We're going to ask that We hold the questions until the end of the session. And so at this time, we're going to invite our second presenter, Miss Tamika Bartley. Now, Miss Bartley is a dedicated researcher who is currently a PhD candidate in her final studies in biochemistry at the University of the West Indies, Mona. She holds a BSc in chemistry and biotechnology, and she has a passion for research in medicinal plants and their natural products. She is an advocate for the promotion of health and wellness using functional foods and medicinal herbs. And in the future, she hopes to establish a career in nutraceutical product formulation and development. So we are welcoming now Ms. Tamika Bartley with her presentation, The Anti-Diabetic Potential of Salvia serratina thickenweed, Active Principles in Sprague-Dawley rats. Thank you. Could you please now make your presentation for us, Ms. Bartley?
Thank you very much for having me. Today, I'll be discussing just a small portion of my research with you. It's entitled The Anti-Diabetic Potential of Salvia serratina, commonly called chickenweed, Active Principles in Sprague-Dawley rats. Okay. For my introduction, I'll be briefly discussing a few of the main points in my research before I go to the methodology. Now, diabetes mellitus is a debilitating disease. It is characterized by hyperglycemia, causing alterations in the metabolisms of carbohydrates, proteins, and fats. There are three main types of this disease: type 1, type 2, and gestational diabetes. The focus of my research is on type 2 diabetes, and it is characterized by insulin resistance and deficiency. In this type, the beta cells are usually functional, but the problem lies in the utilization of insulin, and it accounts for most cases. In order to diagnose diabetes, we look at the blood glucose concentration, and in a normal, healthy individual, the fasting blood glucose reading is supposed to be between 3.9 to 5.6 millimolar, while it should be less than 7.8 millimolar 2 hours postprandial, while for the diabetic state, the fasting readings are over 7 millimolar and greater than 11.1 millimolar 2 hours postprandial. Risk factors associated with diabetes involve obesity or overweight, family history of the disease or history of cardiovascular diseases affecting the heart and blood vessels. Some complications include diabetic retinopathy, hypertension, and heart disease. For the management of the disease, oral hypoglycemic agents are used, and regular health checkup, blood glucose monitoring, and healthy lifestyle are recommended. Now, hypertension is a major complication of this disease, and it is the chronic elevation of blood pressure where the force of the blood on the arterial walls cause health problems such as heart disease. 4 main hemodynamic parameters are normally considered: systolic blood pressure, diastolic blood pressure, mean arterial pressure, and heart rate. According to the CDC in 2019, for a normal individual, the blood pressure for systolic should be less than 120 millimeters of mercury, and for diastolic, it should be less than 80 millimeters of mercury. For stage 1 hypertension, the readings are normally between 140 to 159 millimeters of mercury for systolic, and 90 to 99 millimeters of mercury for the diastolic. Now, traditional medicine have been used. It has introduced the natural products in the form of pills, gargles, oils, infusions, ointments for the treatments of various ailments, and the World Health Organization estimates that 80% of the world's population uses herbal remedies in primary health care. Now, if you were to look at the screen, you would see a picture of the plant that was used in my research, Salvia serratina. It is called chickenweed in Jamaica, and it was used as a blood purifier in traditional Jamaican medicine. Jamaicans who are diabetic use this plant in combination with metformin, and there has been no study found in the literature regarding its hypoglycemic or hypotensive effects. As a part of my research as well, I used the high-fat diet type 2 diabetic rat model. It is the most successful non-genetic model for type 2 diabetes, and it is based on the fact that a very high-fat diet with streptozotocin causes pancreatic beta cell damage as well as permanent insulin resistance. Now, for my justification, diabetes mellitus is projected to affect approximately 700 million people by the year 2045. It is one of the major risk factors for cardiovascular disease development, and the current oral agents are very expensive and they impart unpleasant side effects. Traditional medicine has introduced a number of herbal supplements and nutraceuticals. Therefore, these plant extracts provide an alternative source for more effective remedies for diabetes. My aim is to investigate the effects of Salvia serratina chickenweed active principles on blood glucose concentration, cholesterol level, and blood pressure in normal and high-fat diets, streptozotocin type 2 diabetic rats. In previous studies in my research, I isolated 2 active principles from the plant. They are TBHEFR51, designated S, and NR-TBHE, designated N, and I made a 1-to-1 ratio of combination of these active principles. I created an experimental type 2 diabetic rat model, and we looked at the effects of these principles in terms of the hypoglycemic effect, the effect on the cholesterol level, and the effect of the blood pressure in the rats. Now, for my methodology, for the oral glucose tolerance test, normal healthy rats were collected. They were divided into 3 treatment groups, NR for first active principle, ST, and the combination NR-ST. The rats were fasted overnight for about 12 hours. A fasting blood glucose reading was taken. The drug was administered intravenously or orally. Then glucose readings were taken at the 30 and 60 minutes interval, and at the 60 minutes interval, a glucose load was administered, and then glucose readings were taken for a further 2.5 hours at 30 minutes intervals. For the blood pressure study, normal healthy rats were divided into 4 groups of 6 rats. Normal control, which was given 1% sodium carboxymethyl cellulose, captopril, propranolol, and these 2 drugs are antihypertensive agents, and the combination NR-ST at 40 mg per kilogram body weight daily. Hemodynamic parameters were measured at days 0, 7, and 14 using the CODA non-invasive blood pressure machine as seen in the picture. And for this test, the occlusion cuff followed by the V cuff, if you were to look at the tail of the rat, it was placed around the tail of the rat, and the readings were recorded for 20 minutes. For the diabetes study, 36 rats were collected and divided into 6 treatment groups, as shown in my table. Normal control, normal treated group, high-fat control, diabetes control given glibenclamide, and diabetes treated. For these groups, the normal control and the normal treated rats were given normal diet and water for 7 weeks of the study. High-fat control, diabetic glibenclamide group, and diabetic treated group were given a high-fat diet and water ad libitum for 4 weeks of the study. At the end of week 2, streptozotocin was administered intraperitoneally, And then at the end of week 3, non-fasting blood glucose readings were taken, and the rats with a reading greater than 15 millimolar were considered diabetic. And we used the glibenclamide challenge to confirm type 2 diabetes in these rats. For the remaining 3 weeks of the study, all rats were fed on normal diet and water, along with their designated treatment regimen daily. Non-fasting blood glucose concentration was determined weekly. The rats were anesthetized using sodium pentobarbital, and blood was collected from the renal artery. The serum was separated and stored at -80 degrees Celsius for further studies, and the organs were excised and stored for histology studies. Insulin assay and high-density lipoprotein cholesterol assay were carried out using ELISA kits. Total cholesterol assay was carried out using the Lieberman-Burchard method. Statistical analysis was carried out using the SPSS software, and student t-test was used where p-values less than 0.05 was considered significant. Now for my results, the first active principle, which was designated S, here we can see the glucose tolerance curve. And if you were to look at the black curve, which is for the control, we can see that it shows a regular glucose tolerance curve where there's an increase after the glucose load, and then a decline after 120 minutes due to the action of insulin. For the active principle, we can see that there was a significant decrease in the blood glucose concentration in the fasting region at 60 minutes. For the second active principle, which was designated N, we can see that there was a decrease in the blood glucose concentration at the 30 and 60-minute intervals. Now, these two active principles were taken and combined in a 1-to-1 ratio and administered orally over a period of time, and here we can see that the most effective dosage was at 10 mg per kilogram body weight, if you were to look at the green curve. So it caused a lowering in the blood glucose concentration at the 30 and 60-minute interval. For the serum insulin concentration study, we can see that the normal control and the normal treated serum insulin concentrations were significantly different. So we can say that the treatment in the normal healthy rats was able to increase the insulin production. The high-fat control was also significantly different from the diabetic control, which is a green bar, which shows that when the rats are diabetic, they are producing less insulin, and for the rats in the group of the high-fat control, those would be producing more insulin due to the increase in the free fatty acid present in the serum. Among the diabetic groups, we can see that the glibenclamide group was significantly different from the diabetic control and the diabetic treated group. The diabetic treated group, which was expected to produce some amount of insulin, did not, and we can say that the treatment was not really able to regenerate the beta cells which were damaged during the treatment with streptozotocin. The amount of high-density lipoprotein cholesterol in the diabetic treated group was significantly greater than the other groups, and there was no significant difference in the amount of total cholesterol across the treatment groups. These results support the use of natural products in the improvement of cholesterol in the diet, and the treatment could thus provide support in the diet of diabetic individuals. For the blood pressure study, we can see where the treatment was able to lower the systolic blood pressure at days 7 and 14. However, for diastolic blood pressure, mean arterial pressure, and heart rate, there was no significant difference. Further studies, therefore, required to look at the mechanism of action of the blood pressure lowering effect of NRST in the rats. So, for my conclusion, while NRST treatment was not able to promote insulin secretion in the diabetic rats, it was able to increase insulin secretion in the normal healthy rats. Therefore, further studies may be necessary in the variation of the ratios of both compounds in the combination. There could be a relationship between the observed increase in the high-density lipoprotein cholesterol and the lowering of systolic blood pressure in the rats, even though we did not see a decrease in the diastolic blood pressure. The fact that NRST was able to lower fasting blood glucose concentration and systolic blood pressure, the combination of both compounds may have the potential as an adjunct treatment and improve the management of type 2 diabetes. These are a few of my references, and thank you for listening.
Thank you very, very much for that presentation, Ms. Bartley. I am sure that there will be questions that you will have to answer in the question and answer session, but we are going to move right now straight into our third presentation, and this will be done by Professor Afet McCaw-Binns. So our previous two presenters were budding scientists, and now we have a full-fledged scientist here, well known in Jamaica and across the world, and it is my pleasure to introduce to you Professor Afet McCaw-Binns, a professor of reproductive health and epidemiology in the Department of Community Health and Psychiatry, UWI-MONA. For over 40 years, Professor Binns has focused on research on maternal and perinatal health and vital registration aimed at guiding policy, program design, strategic planning, and evaluation. She has been a consultant to the World Health Organization, the Pan American Health Organization, the United Nations, and International Health Metrics and Evaluation, IHME. Her work in Jamaica has contributed to the development and support of the maternal mortality surveillance and response systems, and to the introduction of specialist antenatal care for high-risk mothers. So here now to make her presentation, Trend in Maternal Survival Among Women with Sickle Cell Disease in Jamaica from 1998 to 2017, is Professor Afet McCaw-Binns. Please proceed. Thank you.
Go ahead. Michelle, thanks for that very kind introduction. Good morning, and today I extend greetings on behalf of my co-authors, Drs. Leroy Campbell and Ardeen Harris, Ms. Leslie Ann James, and Professor Monica Aznani. The differential in maternal mortality between rich and poor countries is one of the greatest inequities in the modern world. Progress on improving maternal health has been very slow, and so today we explore the contribution of one specific problem, sickle cell disease. Maternal deaths result from adverse complications during pregnancy and up to 6 weeks after delivery from either direct obstetric complications or indirect medical conditions aggravated by the physiologic effects of pregnancy. This, however, excludes pregnancy-associated deaths more than 6 weeks after the pregnancy has ended and those due to accidents and violence. More effective contraceptive use has enabled women to delay childbearing. Today, fewer Jamaican women give birth during adolescence or in their 20s than 4 decades ago. In 1998, Jamaica made maternal mortality a Class 1 notifiable event, enabling the reporting of suspected cases to the Ministry of Health. This has been supported by active surveillance, where deaths in women 10 to 50 years of age are reviewed to ensure that all cases have been identified. Case reports are evaluated by regional and national multidisciplinary teams who agree on the causes of death and avoidable factors to inform improvements in care. Since 1981, direct deaths, the larger group there, have been trending down. However, indirect deaths, late and coincidental mortality rates have been increasing. Maternal deaths associated with sickle cell disease, however, have been relatively unchanged over this period. Pregnant women with sickle cell disease experience more frequent crises, infections, and obstetric complications, which elevate their risk of maternal death. Preterm birth contributes to a higher likelihood of perinatal death among their babies. We will compare the relative risk of maternal death between women with and without sickle cell disease by measuring differences in their socio-demographic characteristics, their underlying and immediate causes of death, and healthcare factors. We will also explore what may have changed over 2 decades. And now to our how. Of 1,083 pregnancy-associated deaths in the database, 62 and 26 were excluded as either not being pregnancy-related or of unknown cause. We also excluded 189 late maternal deaths. Of the 806 maternal deaths, similar numbers, 42 and 41 respectively, occurred among women with sickle cell disease between 1998 and 2007, and the later decade 2008 to 17. Fewer deaths were noted in the second decade among the non-sickle cell population, in tandem with a 16% decline in total live births between the 2 review periods. Health teams compile information for cases on their antenatal and hospital care and postmortem findings. They also visit the next of kin to identify challenges with accessing care and document signs and symptoms preceding their latest illness. The underlying and immediate causes of death were summarized using WHO guidelines. To determine the population at risk for calculating mortality rates, sickle cell screening data from public antenatal clinics were applied to registered live births. This yielded an estimated 10,800 births to women with sickle cell disease between 2008 and 2017. Data were analyzed using SPSS and EpiInfo. Categorical data are reported as frequencies and odds ratios, and continuous data as means or medians as appropriate. So what have we learned? Over the 20 years, indirect causes of death account for 1/3 of maternal deaths. Sickle cell complications are included in the blood and immunological disorders category and have been associated with 7% of all deaths. We will see, however, that women with sickle cell disease died from other causes as well. Cardiovascular conditions were the leading indirect cause of death in the non-sickle cell cohort. Direct complications of pregnancy prematurely ended the other 2/3 of lives, mainly due to the hypertensive disorders, obstetric hemorrhage, and complications of abortion. Between 2008 and 2017, 10.8% of maternal deaths were among women with sickle cell disease. Compared to women without sickle cell who died, no differences were seen in their age, number of conception, or successful pregnancies. While there were no differences in the number of antenatal visits or the highest level of hospital in women's parish of residence, those with sickle cell disease were more likely to access high-risk antenatal care. All women with sickle cell disease who delivered did so under obstetric supervision in referral facilities. Most of them, however, died in intensive care or high dependency units. 49% died from complications of their disorder. Their maternal mortality ratio, or MMR, was more than 4 times higher than their non-sickle cell counterparts. After excluding the 20 deaths resulting from their genetic condition, their excess risk of dying in childbirth remained twice as high. While there was no change In the indirect MMR among women with sickle cell disease, the solid brown line, direct deaths among them have trended up, the broken line. There was also a significant increase in indirect deaths among other women over this period, the solid blue line at the bottom. In addition to dying from complications associated with their blood disorder, their risk of death from direct conditions was highest for obstetric infections, the hypertensive disorders of pregnancy, and obstetric emboli. Indirect respiratory infections were also of borderline significance. As sickle cell disease profoundly impacts respiratory, metabolic, cardiovascular, and immunologic health, complications across these systems contributed to their immediate cause of death. There was, however, no difference in pregnancy outcome among the two groups of women. A quarter died undelivered, and sadly, only 35 to 41% succeeded in producing an infant who survived their ordeal. Sickle cell disease remains a consistent cause of maternal death across the African diaspora. While less than 1% of Jamaicans are born with sickle cell disease, more than 10% of maternal deaths occur among these women who are overrepresented in our antenatal clinics as they need more tries to have a baby. Our live birth rate of 55% is similar to the finding from the Jamaica sickle cell cohort that only 57% of their conceptions resulted in a live birth. In 2014, the Ministry of Health began introducing high dependency units into tertiary and selected referral hospitals, the red and pink crosses on the map. This has brought ventilatory support closer to where women live, but these changes have not yet impacted our maternal mortality ratios. Women with sickle cell disease must compete for these scarce resources due to the demographic transition, trauma, and now COVID-19. Transfer of high-risk antenatal patients need to be more efficient if their lives are to be saved. Optimal outcome require better identification of women at high risk of severe morbidity and transfer prior to their deterioration. For women with sickle cell, this may translate into preferential antenatal admission to tertiary centers, as movement can be difficult and they can deteriorate quite rapidly. The health and survival of women of reproductive age has been impacted by lifestyle disorders like obesity. This may explain the growth in direct deaths from the hypertensive disorders and obstetric embolism among women with sickle cell disease. More than half of Jamaican women over 30 years of age in 2017 were obese. If obese, they may also start pregnancy as hypertensives and diabetics, the gray and purple lines, and this risk increases with age. So in summary, in the uphill battle to reduce maternal mortality, we must address the 2- to 4-fold risk women with sickle cell disease face and whose chances of dying in childbirth in Jamaica has not improved in 20 years. Persons with sickle cell disease need a lifetime of specialized care, including genetic counseling and appropriate family planning for couples. Comprehensive screening in pregnancy enables early identification and appropriate care. Research must be accelerated not just locally but globally to develop evidence-based strategies that make pregnancy safer for women with sickle cell disease and their babies. If the global goals for maternal health are to be achieved, Jamaica must contribute by addressing the specific needs of all high-risk populations whose relative prevalence in antenatal clinics will increase as more women survive to adulthood with pre-existing conditions and want children. Guidelines must also address the co-occurrence of lifestyle disorders like obesity, which increase with age, alongside women's increasing need to delay childbearing into their 30s and even 40s. This work would not have been possible without the dedication of our regional Ministry of Health and Statin RGD teams, who enable our access to consistently high-quality data over this period. Finally, we're grateful to families who provide us with information despite their grief. We do this so every Jamaican family can experience and share this joy. Thank you.
Thank you very much, Professor McCaw-Binns. We have had 3 presentations which have basically spanned the gamut. We started off with the presentation that looked on the potential significance of a known zoonotic parasite on the health status of Jamaicans. We then, at a time when a lot of persons are focusing on the use of natural products to increase their state of health, we looked at the effect of a natural product on diabetes mellitus and the anti-diabetic potential of the chicken weed. And finally, we had, I would think, a very sobering presentation from Professor McCaw-Binns, who looked at the significance of sickle cell disease on maternal health and highlighted the need for specialized care for women with sickle cell disease so as to decrease mortality, and, as she so ably put it at the end of her presentation, increase the joy that can be felt by families when you bring home your nice bouncing baby boy or girl. I'm going to open up now to questions, all the questions that you would have been storing throughout the presentations. We'll now give you a chance to have those questions answered. All right.
Clear as mud, no questions. Clear as mud, no questions.
Let me, I see Dr. Tamika, her hand is up. Dr. Tamika, can you go ahead with your question, please?
Sure, thank you very much. Good morning again, all. We have another set of wonderful presentations being done. I have 2 questions, one for Mr. Simoy Noble and another for Ms. Tamika Bartley. I'll start off with Mr. Noble. All right, my question is, did you really do an in-depth data analysis? And if so, what was your carry-home message, or what was the result that you want us to take away from your analysis? You're muted.
Yes, sorry about that. An in-depth analysis was not, thanks for the question. An in-depth analysis was not done. The purpose of the study was to look at this issue of cryptosporidium that was circulating in that subset of patients. The carry-over message from this is that the need for more molecular tools in terms of surveillance, to be more proactive in terms of reactive when it comes down to outbreaks. So surveillance is a key aspect of that, and that's what we are trying to promote at the laboratory level.
Thank you very much. All right, my next question, you have answered my question. So my next question is for Ms. Tamika Bartley. Lovely research. You did your research, and I can see that it was detailed in terms of the number of subgroups that you had. You had about 6 subgroups with 6 samples in terms of your rats. I wonder though if you could have cut down in terms of your subgroups, the number of subgroups that you had, instead of probably 6, say you had 3, where you would have had a greater sample size within those 3 subgroups so that you could have gotten a more powerful result. What do you think about that, Ms. Bartley?
Well, all right. Are you hearing me?
Yes, I'm hearing you.
Okay. Okay, so these results are really reflective of research that has been done over a period of years. So they were not done all at once. For the blood pressure study, I actually chose to use the 2 antihypertensive drugs because I wanted to use 2 that were working by 2 different mechanisms to compare my treatment with, to get a better comparison with my treatment. So in terms of that, I couldn't have used a smaller subgroup. For the diabetic study, I used 6 subgroups because I was inducing using the high-fat diet, and so I had to use a normal control. I had to use a high-fat control and so on. But however, for some of the studies, I actually reused the rats, for example, the normal control rats, which were not given any treatment or any drug or anything. Those rats were reused. So in terms of number of rats and so forth, we use that method to decrease the amount of rats that are being used. But in terms of the subgroups, I couldn't have done it another way.
Okay, thank you, Ms. Bartlett. So that follows up. Did you think your washout period was good enough between treatments in terms of the rats that you reused?
Well, normally we would use a washout period of around 4 weeks. And normally we would check the blood glucose concentration and so forth to ensure that the treatment is not impacting that and so on. So it's they are back to normal. In fact, for some of the treatment groups, we do not reuse those rats. So for example, if I used glibenclamide on a set of rats, I wouldn't use those rats and do a washout period. More than likely it would be if I used a set of rats and I did one of the active principles, considering that it's coming from the same plant, then I would wash out those rats. So it depends on what the rats are given.
Thank you very much, Ms. Bartley. Thank you guys for answering my question. Prof. McCobbins, I'm just saying hello. I don't have any questions for you. Thank you again. All well done to the presenters.
Okay, thank you, Dr. Royal Thomas. We're now going to move on to other questions. I see Dr. Alonge has her hand up. Dr. Patience Alonge, would you please proceed with your question?
Thank you, Dr. Hamilton. Thank you, presenters, for excellent presentation. I have questions for Mr. Noble. Okay. Yeah. I have a question for Mr. Noble. I realized that you had made mention of cryptosporidium being a part of the routine test, because normally we will test for Escherichia coli. So for this particular research, as it relates to our water systems, are you suggesting that it be a routine test within that system?
Correct. And we are planning to conduct a wastewater treatment analysis for cryptosporidium, because wastewater can provide us with data can give us an early indicator of an outbreak which is occurring at a population or community level. So wastewater, for future studies, we plan to look at water and wastewater treatment facilities and see how effective they are at removing cryptosporidium from their systems.
Okay, so for those in the water, who provide us with potable water, are they going to have access to the laboratory techniques that are readily, handfully available for them to utilize Is that part of your plan, how you can make?
Yes, correct. So the standardized gold standard that is used in the laboratory is not sensitive enough. So hence we plan to use more molecular tools such as PCR and sequencing. And also with wastewater, with water treatment, it requires a more stringent concentration method. Hence, we need specialized equipment to facilitate that. So we are in discussion with private sector companies to help set up a water sampling facility at the university.
Okay, thank you. Thank you.
You're welcome.
My next question, please, if I may, it goes to Ms. Tamika Barclay. Thank you for your presentation. I have a quick question. That was excellent work done. And I appreciate your vision to use natural products to treat and care for non-communicable diseases. I just wanted to find out, even in this season of the pandemic, have you been able to look at simple remedy for the COVID-19 since you have been doing a lot of research in this area, looking at the symptoms and the signs that we see that is readily promoted? Is there anything in your knowledge that could be useful? Have you looked at that?
Okay. In terms of COVID-19, since it is a virus disease and it causes flu symptoms and so forth, most naturally you would use citrus-related fruits, and like you would ensure that you stock up on your vitamin C and so forth, or you would just take your citrus-related fruits like oranges and so on to help with your system.
Well, that will just be sufficient?
Well, not necessarily, but I am sure you would also be on your medications and as well as practicing your regular healthy lifestyle and having a healthy diet and so on.
Okay, thank you. Thank you very much. Thank you, appreciate it. Professor McBean, thank you very much for your excellent presentation. I was so excited listening to you. My quick question was, those individuals that have sickle cell, I have family members who in Nigeria who had sickle cell. They had children, they survived, but I'm more concerned as well. Is it a case where we are not doing, what do they call it? Testing enough? Do we have the genetic testing that we encourage young persons before they get involved so that the knowledge of their disorder alongside with their partner, that could make it much more easier for survivor, as well as having healthy babies that will live so the babies don't die, as well as keeping the mother alive?
Well, the challenge we have in our setting is that we frequently only see the patients, in the late first or second trimester when they are already pregnant. So pre-pregnancy counseling and testing of partners doesn't really apply very well in our setting. And even if we could do genetic testing, termination of pregnancies that are affected is not something that is socially and culturally accepted in our setting. So we have to focus on improving early identification of cases and improving the quality of care. And this is where the whole issue of more research needs to be done to what are the kinds of evidence-based methods that work for improving outcomes in these patients. More work needs to be done in that area. And, when a patient gets into problems and she's out in Lucy, how does she get to a tertiary hospital where there is a ventilator to keep her going? When you look online and you look at some of these patients with COVID that need significant respiratory intervention, we can't do those things. So prevention is our best strategy for managing problems. So we have to be a little bit more thoughtful in what happens. It's difficult to move a patient once they are in challenges. So, you know, what do we advise these patients? Show up at the right place so in the event that problems occur, you are there to get the necessary interventions. It's a problem in our setting. And couples, there are couples that make decisions that they're not going to chance a pregnancy in a patient with sickle cell disease, and so they talk about things like adoption in other settings. But, you know, that is just a big issue where we are.
Thank you, Professor McBain. So education could also be for the younger generation. Thank you.
Okay, thank you. As you are aware, courtesy of COVID, we are joining via Zoom, but we also have a number of persons in-house, and I understand that there's a question from an in-house participant. So would we please have that question now?
Hi, good morning. It's a question to Ms. Bartley. So the NRST fraction had an effect on lipids but not glucose. Did you have a different result with the other fraction?
Okay, so it had an effect on the glucose level in the fasting state. So yes, it had an effect on the high density lipoprotein cholesterol, and it also, as based on the graph I showed, it was also able to lower the blood glucose concentration in the fasting area of the glucose curve at 10 mg per kilogram body weight.
Okay, thank you.
I see a note that 2 participants have raised their hands, but I'm not able to see the hands raised at this time. So can one of you who have raised your hands? Okay, I see Marva Brissett. Can you please ask your question now? Marva Brissett? Right. And if you are not ready, I see Alice Carney. So Alice Carney, can you ask your question now? Okay. I think that these participants are having a little challenge in unmuting. So if we don't have any other questions, then I think we would be looking to wrap up shortly. Are there any other questions?
Dr. Hamilton?
Yes.
There is a question in the question and answer session.
Right. I'm seeing it now from Shani Jones.
No, from Kusha Singh.
Afternoon. So that question is for Professor McCobbins. Do you think that this is the time to have specialized comprehensive care clinic for SCD clients in primary care where accessibility issues are?
I'm not sure I'm getting the question. I'm understanding the question. They want specialty clinics for patients with sexually transmitted infections, but they want them separate and apart from everybody else.
No, SCD.
Sickle cell disease. I think it can be integrated into we already have high-risk clinics. It's just that we need to have clear guidelines for what are our leading complications of pregnancy so that there are guidelines for what specific types of patients need. And we're necessary to coordinate between the high-risk antenatal clinic providers and the other specialty consultants. So if we have a patient with sickle cell disease, that there be some consultation with the hematologist in managing these patients, that we have guidelines that are developed with the hematologist to guide these persons to make their most appropriate decisions in terms of how to manage these patients. We have to be a little bit more limber with how we deal with our problems and make the best use of our resources. And guidelines are one of the ways to do this.
Thank you.
Okay, there's a question in the chat from Shani Jones. I expect that this is going to Miss Bartley. It says, with our thrust towards using natural medicine more and more, how can this be used to enhance prevention of deforestation and harm to our forests? So, Miss Bartley, could you take that, please?
I'm not so sure I heard the question clearly. Is it possible?
It's with our thrust towards using natural medicine more and more. How can this be used to enhance prevention of deforestation and harm to our forests? In other words, how can we protect our plants since you are using a plant, you know, for medicinal purposes?
Okay, so I would suggest that once a plant is identified as a source for a useful natural product, that we could actually have special nurseries where these plants are grown. So instead of removing the plants from their natural habitat, you just take maybe a small sample and then you grow these plants for the purpose of natural products.
So you are not thinking of promoting their existence in the wild. You are thinking of identifying plants that can be used for medicinal purposes and cultivating those for that purpose.
Right. So you don't have to eradicate them from their natural habitat.
Right. I suspect too that what this question was aimed at is not so much you're eradicating them from the natural environment, but preventing others from coming and removing trees and plants, because we now have an emphasis on the fact that some of the plants that you could be removing could have impact, a medicinal value. So using the fact that plants, even if you don't know what types of plants they are, could be of value to us. Be careful when you clear the forest. Be careful when you just, bush an area, because you could be getting rid of the next best thing in medicine. So you are being encouraged, I would think, from this question to try to advocate for keeping plants, and protecting natural habitats so that we can protect the potential of plants to have effects upon our health and well-being. There is one question I would like to ask from Mr. Noble. And at the start of your presentation, you spoke about the fact that Cryptosporidium, the infection, you gave us rates for immunocompetent children and immunosuppressed adults. So those are the two groups of patients that would be expected to be more susceptible then to your Cryptosporidium infection. Did you look at, in the positive cases, was there any correlation with the patient groups? And particularly, you found one species that had not been identified before. Do you have any information on the profile of the patient that would have had this infection?
So we are currently in the process of trying to get information from the patient, because these samples were stored from 2016 to 2018, and so we're trying to ascertain information from the patient as we speak. So we don't have the information at hand now.
Okay. So sorry, go ahead.
Also, what would have been ideal is that we could have seen it's a zoonotic parasite, and it's host adapted. The species that was isolated was host adapted to tortoises. We're assuming or predicting that this was for exotic pets, like tortoise people, person having tortoises as pet or pet snakes, seeing it is a parasite of reptiles. So we're assuming that this is from when they were cleaning the cages or so forth, they contracted this infection.
Okay, and of course we can see the significance of that type of result on how we advise persons to have these exotic pets and how they would care for them if they in fact had them.
Correct, and also hand hygiene is also key as well, because it's transmitted through the fecal oral route as well.
Could it be, since you have mentioned turtles, and we know that we are not supposed to kill the turtles on the beaches, but some of them still die. Could this be contracted from eating improperly cooked turtle meat, since we are mentioning turtles? Don't we have to ask? It's something we know about.
That was one of the ideas that we came up, one of the things we were thinking of as well, seeing it from pets or the consumption of tortoises, the meat.
And we can see how we spoke about laboratory data informing public health decision making. So depending on the source of the species and the manner in which we think it was, the infection was contracted, you can see recommendations going forward also to persons who are going to be not just having these animals as pets, but also consuming the meat. So think about the applications to, our public health decision making and the sort of guidelines that we give to our population. Okay, thank you so much. And are there any more questions? I think, we could say going once, going twice. Okay, very good. Well, thank you. Well, it's over now. We have closed off. So thank you very much. This has really been a very powerful session, and I'm sure it's given us much food for thought. And I would say in closing, thank you for 3 excellent presentations. And all of us know someone who is affected by sickle cell disease, or know someone who knows someone. And I think we should think very carefully on what Professor McCall-Binns has highlighted to us in terms of our discussions with these persons, and encourage, of course, maximum precautions in terms of their health status, because we would all like to share the joys of maternal bliss as opposed to the sorrows of maternal mortality. And so I would like to thank you all for your participation, and I would like to turn you over now to I'd like to turn you over now to the moderator for the day.
Okay, we want to thank Dr. Hamilton for moderating that session, and we also want to thank our presenters, Mr. Simoy Noble, Ms. Tamika Bartley, and Professor Afet McCall-Binns. That was a very enriching session, and many questions were answered and raised, and we hope that the research will be able to go on in terms of continuing to raise questions. So one of the panelists has asked a question about how we can encourage our young researchers, and I think we have seen the quality of work not just today, but also yesterday evening in terms of our young researchers. And yes, the ministry is looking into granting research for wellness and also in terms of postgraduate studies. And I think we have to find ways to encourage the next generation of researchers. So at this time, we are going to take a 5-minute break. We are well behind time, and we'll have to try and see how we can catch up between this session and lunchtime. But I know that our panelists are ready and waiting, and we do have a treat in store for us. The next session will be a panel discussion on men's health, a multidimensional perspective, and that will be moderated by Dr. Belinda Morrison. And the panelists will be Professor William Aiken, Dr. Donovan Thomas, and Professor Rachel Irvin. And they are all ready, so let us try to meet back at 18 past. Well, let us just give a whole number, so we'll start back at 12:20, no later. All right, thank you.
First, congratulate the Ministry of Health and Wellness on their 12th Annual National Research Virtual Conference. I hope that you have a wonderful day and what is learned will be used to the development of Jamaica. The Road Safety Unit aims to promote and foster a safe traffic environment for all road users. The goal is to prevent road crash injuries and fatalities. To date, we have lost 391 persons on the nation's network, and the unit recognizes the undue burden road crash victims place on the hospital system. The COVID pandemic highlighted the burdens our healthcare system has to endure, and we recognize how road crash victims redivert resources from treatment to emergency trauma care. With that in mind, the Road Safety Unit and the Ministry of Health and Wellness would like to make road crashes a thing of the past. As we continue to work together to ensure that the burdens placed on hospitals and healthcare systems due to road crash victims or road crash injuries become a thing of the past. We celebrate the Ministry of Health and Wellness's efforts and hope that your virtual conference is a success. Thank you.
Severe pains, shortness of breath, worsening with fever, lack of appetite, extreme weakness, and overall grazing beside death's door. This was my experience with COVID-19. Hi, I'm John, and I'm so thankful that I survived COVID-19. As an asthmatic person who lives alone, I know that COVID could have claimed my life. Listen, don't drop your guard with COVID-19. It only takes a second for you to catch a virus. Initially, I thought I had the flu until things got worse. Don't leave your mask, wash your hands as often as you can, and always keep a physical distance from others. And I want to tell every Jamaican to choose a vaccine before COVID chooses you.
A message endorsed by the Ministry of Health and Wellness. Healthcare workers are working very hard to ensure lives are saved and people recover quickly from COVID-19. But their work is becoming harder because you're not wearing your mask, washing your hands with soap and water, or using hand sanitizer, and you are not maintaining physical distance. Let's limit the need for hospital beds and ventilators. Do the right thing. Cover your nose and mouth with a mask. Practice good hand hygiene and maintain a physical distance of 6 feet between you and others. COVID-19 is not over. Protect yourself while protecting others. A message from the Ministry of Health and Wellness.
Become the hero on the scene by taking the COVID vaccine. Become the hero on the scene by taking the COVID vaccine. Get vaccinated as soon as you get all the facts. Don't listen to the rumors. This vaccine might just make it possible for teachers to sit face to face with schoolers. This vaccine make it safer for everybody, from the young to the young.
So we are now at the Good Samaritan Inn, which is one of our primary locations today for the first vaccines to be administered to frontline workers and vulnerable groups. So far it's been a good day. We started at 8 o'clock, it's now 10 minutes after 10, and a number of persons have gotten their vaccine, including public health nurses, President of the Nurse Association, former Prime Ministers Golding and Pattison, and many others. It has gone smoothly so far.
Get vaccinated as soon as you get all the facts. Don't listen to the rumors.
I'm encouraging all Jamaicans, healthcare workers, frontline workers, elderly, all persons with comorbidities who are going to be offered the vaccine. I know that there is apprehension out there. I know that persons are afraid. Some persons will tell you don't go. They say I'm not going to go. But I am encouraging you, not just as a healthcare worker, but as a regular Jamaican, protect yourself from COVID-19 infection.
Get vaccinated as soon as you get all the facts. Don't listen to the rumors.
If you are 60 or older like me and have underlying health conditions such as high blood pressure and diabetes, you are at a greater risk for severe illness or death from COVID-19.
After more than a year of being under COVID restrictions, it is also time to do what is necessary to get back to life. That's why senior citizens have been prioritized for vaccination.
The vaccine is safe and effective. I have taken it and I'm feeling just fine.
I've also taken the vaccine and I feel so much more at ease.
Get vaccinated and get back to life.
This is an important message from the Ministry of Health and Wellness.
Vaccine 60. Let's go. All approved COVID-19 vaccines are effective against COVID-19 and all known COVID-19 variants. The Johnson & Johnson vaccine requires 1 dose. The Moderna, Pfizer, and AstraZeneca vaccines require 2 doses. You are considered fully vaccinated 14 days after receiving the required number of doses. Don't mix and match 2-dose vaccines. Get the same vaccine for both doses. Vaccines help to prevent hospitalization and death associated with COVID-19. Common vaccine side effects are usually mild and usually resolve in a few days. After getting vaccinated, it's still important to wear a mask, wash hands or sanitize regularly, and maintain physical distance. The quicker we all get vaccinated, the sooner we can all get back to life. Let's strike gold like our Olympians, Jamaica. That was a message from the Ministry of Health and Wellness.
COVID has stressed me. Do take the vaccine.
And through it all, our healthcare workers have been the real MVPs tackling COVID-19. Caring for you is our priority. As frontliners in the pandemic, they got vaccinated.
I got the vax. I had to protect myself so that I can protect you. No, sir?
Me, stop fret because my vax up.
I made sure my mom and I got the vaccine. Protection is key.
Me, vax up, me stop fret.
Fam, help us protect you, your family and friends.
So should you.
Enough now. Take the vaccine.
Get vaccinated. Get back to life.
Become the hero on the scene by taking the COVID vaccine. Get vaccinated as soon as you get all the facts. Don't listen to the rumors. This vaccine might just make it possible for teachers to sit face to face with schoolers. This vaccine make it safer for everybody, from the young to the elderly. Don't you want to go back to living normally when things were more orderly? And if you want to live a long good life, then we all have to do what's right. So let's get vaccinated along with the heroes on the front line.
A message from the Ministry of Health and Wellness.
Booking your COVID-19 vaccination appointment is simple. Use one of 2 options. Option 1. Register using the online portal at the Ministry of Health and Wellness's website. Go to www.moh.gov.jm, click Apply here for COVID-19 vaccinations, and follow the instructions on screen. Enter your mobile phone number. You will receive a text message with a one-time password. Enter it on the site to confirm your account. Fill in the information requested. Choose your parish and a vaccination center there. Then schedule a date and time convenient to you. You will receive a text confirmation with the details of your appointment. Option 2. You may also book your vaccination appointment via telephone. Call the National Vaccination Center at 888-1-LOVE. That's 888-663-5683. A representative will take your information, book you at the nearest vaccination site, and register your appointment. You now have a vaccination appointment. For your first dose, when going to the site, take your TRN and a government-issued identification or letter from a Justice of the Peace. For your second dose, take to the appointment your vaccination card, TRN, and a government-issued identification or letter from a Justice of the Peace. You may ask a relative or friend to help you book your vaccination appointment. Book your COVID-19 vaccination appointment today. Get vaccinated. Get back to life.
Some of we have all sorts of excuse as to why we don't want to wear the mask. The place too hot. We're not used to it. It's not comfortable. Look, you know. Wake up and smell the country chocolate. Them excuse, they're not going to make it. You may know the place hot. But you don't want to feel COVID-19 fire in your lungs. And used to. The only way to get used to a thing is with practice. So practice and wear your mask. And
Good afternoon again, everyone, and welcome back. We are now ready to begin our next session, which will be a panel discussion on men's health, a multidimensional perspective. And at this time, I'm going to hand over into the more than capable hands of Dr. Belinda Morrison, who is a consultant urologist and lecturer at the UWI. Dr. Morrison, welcome, and over to you.
Thank you. It's my great pleasure to moderate what I think will be an exciting session this afternoon. I know we're deviating a little bit from the general conference theme, but today we will discuss men's health, a multidimensional perspective, and we have quite a competent, more than competent set of presenters and panelists today to discuss this topic. I will first welcome Professor Rachel Irvin, who is a professor of biochemistry and sports science in the Faculty of Medical Sciences at the University of the West Indies. She completed her postgraduate work at Rockefeller University and Brown University in the US, and also obtained a diploma in immunohematology, and is currently director of one of Jamaica's COVID-19 testing labs. She's the first female to be appointed professor of both biochemistry and sports science in the English-speaking Caribbean. She's written over 100 articles and manuscripts in peer-reviewed journals, and she's a best-selling author of a sports science book, Jamaican Gold, Jamaican Sprinters. She previously sat on the board of the directors of the Jamaica Anti-Doping Commission and loves to present on men's health issues, hence her being one of our featured panelists today. She grew up in a majority male household, and most of her postgrad studies she supervised, or supervisees were at UWI were males. So please welcome Professor Rachel Irvin, where she will speak for the next 10 minutes on men's health.
Slide. I have a slideshow. My slide is not up.
Can we get your slides, please?
Hi. Can you hear me? Wait. I'll be presenting on a multi-dimensional perspective, men's health. We will talk about COVID, sports testing, vaccination strategies, and surprises. Next slide, please. So, to tell you more about men and surprises, we did a little study on the natural progression of COVID-19 in asymptomatic Jamaican male athletes. We did a longitudinal study of about 14 young males who were asymptomatic. They had COVID and swear they never had COVID, but they were detected in competition. Some of them performed and performed well because they convinced themselves that they didn't have COVID. Some of them thought they could perform, and when they went to the Olympics, didn't do as well as they thought they would. Next slide, please. So, a preamble. The reaction, the immune response to COVID is varied. Specific population react in specific way. If you look in a magazine like Nature, Lancet, you will see that some person have an accelerated white cell response, high white cell count. With some person, it's normal. With other persons, the lymphocytes are high. Other persons, it's low. So it is very important that persons who are at low index, of suspicion for COVID be identified, because sometimes there might be effects that are long-lasting, but you can't convince persons that it will affect them. So you need to identify them and have a plan of action. Next slide, please. So we know much about people who are sick. We have a lot of data, and rightly so, but we need to know about persons who might be sick and don't know that they are sick. Example, about 10 of our male athletes were tested in Kenya. They were positive, and even when they came back and we were studying them, they said, listen, miss, I was never positive. Even though I was congested and I felt a little bit weak, I still performed. They medal. Actually, they medal. So, you know, I said to them, okay. I said to them, listen, you were positive. It is noted. We got the results from the RT-PCR that came from abroad. And we actually had to do the tests to prove to them that they were positive, meaning we had to do the antibodies to the COVID antigen to prove to them that they were positive. One actually was positive and went and performed. Didn't perform as well as he did. And he said it was because he had traveled, not because he had COVID. So what was the rationale for this study? We need to have a picture, not just of the sick persons, but of persons who are sick and don't believe that they are sick. We need to have a profile in a setting because, you know, men play dominoes and they play football. They might have COVID and they might spread COVID. If they know they are at risk for COVID, in spite of them being buff and being healthy, then we can plan around a strategy. It means that if they know they are at risk for COVID, they will also take the vaccine. So it's a vaccine strategy as well. Oh boy, this thing not working. Oh, there are. Okay. So the rationale is that we needed to have the information about some people who might feel that they could never have COVID. What did we do? Okay, I'm fine. What did we do? We looked on social media. We saw that some of them were positive. We identified them, we approached them. We did an antibody test for some antigen of COVID. We did the rapid antigen test to find out whether they were reinfected, and we did the CBC. Let us look at our results. We looked at about 11 persons. The youngest male was 14, the oldest was 27. Most of them were asymptomatic, 73%, 27% was symptomatic, and symptomatic, they just had a little bit of stuffiness. We looked at antibodies. Most of them had 1 or 2 antibodies to the COVID antigen. Just 1 didn't have any antibodies at all. Most of them were Delta positive. We sent away some of the samples, and most of them had the Delta variant. I want you to look at this classic example of a 14-year-old. We looked at his CBC. What was noteworthy about this is that his MPV, mean platelet volume, was low. The platelet numbers, normal platelet count, the numbers were okay. He had a normal white cell count. The lymphocytes were high. His basophil was high. Classic response in those persons who are asymptomatic or mildly symptomatic. We looked at an 18-year-old, and what did we find? That even at 4 weeks after the COVID infection, the MPV, mean platelet volume, was still low. The basophil was high. There was a little bit of problem with the red blood cell, even though the hemoglobin was normal. At 4 weeks, there is still some indicating that there is still some inflammatory process. We also look at testosterone. And we wanted to look at testosterone because Nicki Minaj had said that when you get vaccinated, your testicles might get swollen. So we wanted to look at, COVID to see if COVID had any impact on circulating testosterone. And we found that testosterone level was a little bit low. What was fascinating to me, and the most fascinating case, was this young man at age 27, 6 to 7 months after COVID, he still had some inflammatory processes going on in his system. He was a former world champion medal winner, and he just never performed at the Olympics. And he swear he was okay. He swear he was okay. But when we look, his MPV, mean platelet volume, was low, and his basophil was still high. It means also that some of the guys that performed at the Olympics and didn't perform well might have had some problem with COVID. And what this means is that for anti-doping processes, the testosterone might be affected. There might be some inflammatory processes. So you are checked by water and you don't know that you had COVID, and your blood passport is AY, your parameters are AY, and you are sanctioned, it might mean that you had COVID, and when you were checked, the inflammatory processes are still going on, even though you test negative. It means for public health and for anti-doping policies, what we need to do is identify our sportspersons who are at risk, make sure we have a profile on them. We also need to identify our sportsperson who had COVID to find out if they still have inflammatory processes 6 months or long after, and not cry down our males who didn't perform at the Olympics. Because this might have been a reason. Many of them might have been exposed to COVID, don't know that they have COVID, swear that they don't have COVID even when they tested positive, but we're suffering. We're suffering. How do we get normal data of our male who are too probably ashamed, or not even ashamed, they just don't want to say they have COVID. But if we have the data to say to them, hey, listen, even if you're fit, even if you have a six-pack, even if you're an athlete, you might be impacted by COVID. So listen, you need to take the vaccine. So this might be a way of for the Ministry of Health to come up with some strategy to say, listen, athletes we have proven that athletes can have long-haul COVID even when they are asymptomatic. So I wish that we could expand on this study so that we have a strategy to approach some of our males who are reluctant to take the vaccine. Thank you.
Thank you so much, Professor Irvin. A very, very interesting study, and I'm sure a lot of questions will be generated during the discussion segment. I will move on next. Our next presenter, Dr. Donovan Thomas. Dr. Thomas is the founder and president of Choose Life International, which is a non-profit organization, which is also a member of the International Association for Suicide Prevention. He's a former national director of Jamaica Youth for Christ, a post he's held for 14 years, and a past regional director for Youth for Christ International in the Caribbean. He is a graduate of the Jamaica Theological Seminary and holds a doctorate in ministry from Columbia Theological Seminary in Atlanta, Georgia, and has conducted extensive research on the subject, confronting suicidal propensity among Jamaican teenagers. He first became involved in working with suicidal persons for over 30 years ago, and we welcome him to the discussion on men's health, a multidimensional perspective. Thank you. Dr. Thomas?
Madam Chair, fellow presenters, ladies and gentlemen, good afternoon to all of you. From the outset, I'd like to express my appreciation for the opportunity to be able to share in this conversation today, this panel discussion, men's health, a multi-dimensional perspective. In fact, that's the model on which Choose Life International is built. We believe in the biopsychosocial spiritual model of support to both males and females. Our model is rooted in the conviction that every aspect of an individual's life is important and that we need to be able to help people process. We know IQ very well, we know EQ very well, but there's also the SQ, which is the spiritual quotient, which brings empowerment to persons' lives. Luke 2:52 is a scripture that has helped to undergird our conviction about this model that says, Jesus increased in wisdom, in stature, and in favor with God and man. We're going to be focusing today a little bit about the psychosocial. And when we talk about the psychosocial, we're talking about relating to the psychological and social aspects of an individual. Factors include work environment, loneliness, marriage, and the list goes on. There are 7 psychosocial factors impacting men that I'd like to highlight right now. Traumatic experiences, employment issues, relationship issues, legal or financial concerns, family history of mental health issues, misuse of alcohol and other drugs, other life-changing challenges, physical illnesses, illness of loved ones. What are some of the signs of psychosocial concerns in men? Noticeable changes in energy level or mood, appetite changes, anger, aggression, and irritability, compulsive or reckless behavior, difficulty concentrating, feelings of hopelessness, changes in eating and sleeping habits, and the list could go on and on that many of that you are very familiar with. And I'd like to just add a little bit talking about suicide. And I'd like to just interact a little bit with the issue of gender suicide. Yes, we know that men complete suicide more while women attempt more. But we want to say, as we interface with men, we need to listen to what they are saying. What is the talk? Are they talking about being burdened, about killing self, about having no reason to live? What is the kind of mood that they are displaying? Depression, irritability, anxiety? What about their behavior? Are they involved in risky behavior, sleeping too much, writing notes, visiting people, saying goodbye? Those may be some warning signs. We look at some of the stats concerning suicide in Jamaica, and in my own assessment from 2013 to 2017, of the 259 persons that completed suicide, 35 were females, that is 14%, and 86% of those who completed suicide were males. 224 of the 259. Why do more men complete suicide compared to women? Psychological factors, yes. The man does not talk about what's bothering him generally. We do not usually initiate going for help. There is the economic concern, and to a very large extent, man is still considered to be the breadwinner. So strong is the relationship between economy and suicide that a new word, econocide, has been formed. Then there's the socialization factors. 2 3-year-olds are playing, a boy and a girl. Both of them fall. How does the average person respond to the boy? How does the average person respond to the girl? Usually it's a pick up and a brush off for the girl and probably a kiss. Hush, darling, don't cry. But for the men, for the young, sometimes it is a slap. Get up. You're a man. Be strong. Don't cry. And from very early, we're teaching our boys that it is inappropriate to express feelings. Then there's the religious factors. Jamaica is a very religious country. The largest religious group in Jamaica is Christianity, and the place of worship of the Christians is called church. Pre-COVID and Zoom during COVID, yes. Who do we find in those places of worship? More males or females? Many more females. They know that this too will pass. So men are less involved in religious activities, and they unlike the women, they do not get to the point most of the times where they know that God is able to help them bear what's going on. Males are 4 times more likely to die from suicide than females. However, females are more likely to attempt that suicide than males. Of course, men use more drastic means. And usually a man says it's over, it is over. 51% of those who die by suicide in the US do so by gun. Yes, in the Jamaican context, it is hanging. Men use more drastic means. What to do if we recognize that somebody is suicidal? Do not ignore the threat. Do not leave him alone. Do not say how much family and friends will be hurt, because many of the persons attempting suicide are hurt in the context of family, and they really want to get back at those who have hurt them. Do not look shocked or embarrassed at anything. Do not try to solve the person's problem on your own. Yes, we want to move it to the next level. When are men more likely to seek help? Men are more likely to seek help when they perceive that their problems as normative and central to an important quality of life. They seek help when it is consistent with the characteristics of the social group in which they dwell. They are more likely to seek help when they feel inspired by what they see of the potential caregiver. If the potential caregiver comes across as a potential helper, comes across as being caring, considerate, non-judgmental, they are more likely to reach out for help in that kind of context. They are more likely to reach out for help when they perceive that they would have some amount of control still. Man does not want to give up the control. They are more likely to seek help, or we are more likely to seek help when the extent to which we feel we can maintain change. Let me say that again. When there is a great extent to which we feel that, yes, we are going to go to counseling and we are going to be able to get help to maintain the change. As we seek to help men with this psychosocial, in their psychosocial context, we realize that we have to come up with strategies that are more easily received by the man. Coaching or lifestyle training may be less threatening to men than counseling or therapy. Men will stay away from the people who are called counselors, but they may be more likely to discuss coaching, where the psychosocial programs such as anger management and emotional intelligence seminars may attract men because it is less threatening, and they like to think we don't need counseling. In the context of the business place, where there's employee assistance workshops offered in this context may carry less stigma, and men may be able to may be more comfortable tapping into this kind of help. They find it more comfortable being involved in men's group. Men's group may provide a safe climate for exploring gender stereotypes and concerns about adequacy as a man. Men are more comfortable seeking help when they have an opportunity to reciprocate. They want to be able to give back. They want to be able to give back. They want to be involved in groups. They want to be able to share. They want to be able to find ways to be able to serve. Even in terms of internet, mutual help, chat rooms, those are opportunities, and we may be able to pull men in as we seek to get them involved, and that may be the place at which we're able to bring about transformation or help them see themselves and get the help they need. 5 R's as we seek to help men with psychosocial issues. Let's respect them. Let's reject the notion that they can't change. Let's recommit to doing all we can to be able to reach them at their level. Reach out. And remember, the help that you provide could be that which transforms his life, the life of the family members, and the nation in their spheres of operation. Be calm. As we seek to help men, I want to encourage us to be alert, express empathy. And this is an acrostic here I'm sharing with you. Be calm. Control what you have control over. Assure him of your support. Listen without being judgmental. And move to the next level of help. We may need specialists to be able to help us. We've done that so many times. This is what is going to help us to be able to get the best result from men. Again, we affirm, we believe in the biopsychosocial spiritual model of intervention. And there are practical steps we can take to be able to provide support for men in these challenging days. Many times we realize that the presentation, what we see up front can be very just protective. They want us to be able to penetrate that so we can get the real you, the real man that is hurting and really wants to get the help they need in the midst of the challenges. Here are some sources that I have consulted as we have interacted with this preparation, and the contact information should you need to have further dialogue. I thank you very much.
Thank you again, Dr. Thomas, and we will hear more from you a little bit later on. Our next panelist needs no introduction. I think most of us are well aware of who Professor William Aiken is. He is a colleague and friend and a consultant urologist and professor of urology in the Department of Surgery at the University of the West Indies with over 20 clinical years of experience in urology. He is a former head and supervisor of the Doctor of Medicine program in urology and teaches both undergraduate and postgraduate medical students. He is past president of the Caribbean Urological Association, a member of several professional organizations, including the American Urological Association, and also a member of the African Caribbean Consortium. His active areas of research include investigating the epidemiology of prostate cancer, health disparities research, and epidemiological aspects of sprinting prowess and prostate cancer. I will now welcome Professor Aiken to the discussion on men's health.
Thank you, Dr. Morrison, and thank you to the organizers for inviting me to participate in this conference. I don't have any slides to share, but what I'll be doing is speaking about men's health in general. So in 2011, Morris et al. Published data based on her evaluation of over 5,000 men, 55 years and older, Jamaican men. And she found that 67% of them, or over 2/3, had not seen a doctor in the previous year, documenting the well-known fact that men have very poor health-seeking behavior. Only 35% of these men had done a digital rectal examination or a prostate-specific test, indicating that only a small percentage of our men who should be doing these tests are in fact doing them. Morrison et al., our chairperson, demonstrated that at the Jamaica Cancer Society, only 59% of men who were earmarked to do a prostate biopsy did in fact do so. And men who should have been coming yearly for screening did not do so. A lot of them only did a one-off visit. McNaughton et al. In 2011 showed that cognitive awareness of prostate cancer did not affect screening behavior among physicians at the University of the West Indies, documenting the well-known fact that cognitive awareness of a disease does not necessarily change behavior. Statin has demonstrated or shown that our population is aging rapidly. By the year 2030, our over 65s are going to double from the current prevalence of 8% to over 16%. So our population is aging. The Jamaica Health and Lifestyle Survey, the third iteration, demonstrated also that our population is becoming more obese. Only 21% of our population has health insurance. And Dr. Dooladale, Willie Tyndale demonstrated that men considered access to health insurance an important determinant of whether they sought health care or not, whether they had health insurance. These are some of the challenges that we face. Moreover, the men who are coming in for prostate cancer screening, for example, prostate cancer being the #1 cancer causing mortality in our population. Based on data published by Morrison et al., we know that the population of men being screened is different from the population of men who are actually developing cancers. And the data clearly shows it. The median PSA of men diagnosed with prostate cancer from prostate cancer screening at the Jamaica Cancer Society was 8.9 nanograms per mil versus the men who were diagnosed with prostate cancer or presented to the university with a diagnosis of prostate cancer being 20 nanograms per mil. When we compare men in Chicago to men in Jamaica recently diagnosed with prostate cancer, we see that their median PSA of 9 more closely matches that of the men who are being screened for prostate cancer. What am I saying here? I'm making these comparisons to show that we're not reaching the population of men who need to be reached. The men who are coming to the Jamaica Cancer Society for screening are men who are well aware of the disease. Again, Morrison showed that 84% of them were knowledgeable about prostate cancer. When Shaw in Jamaica prostate cancer study was done at the university, more than 75% of our patients with prostate cancer were unaware of the disease prior to diagnosis. So what we have been doing, I share these statistics to suggest that what we have been doing in trying to make a dent in the prostate cancer mortality, it's not working. We are inviting men to come into the Cancer Society to be screened, but these are healthy men, well men. We need to take a different approach. We need to go out into the communities where these men are, where these men live, where these men socialize, and we need to take this message to them. Recognizing that, as I said, cognitive awareness of a disease does not necessarily change behavior. And in that regard, we need a prostate cancer champion. We need someone who Jamaican men respect, who they look up to, who can serve as a role model to champion prostate cancer screening. Because if without that, we're not going to reach the men. The men hear the message, it goes in one ear, it goes out the other. But if they see someone who they respect and look up to, actually screening and recommending it, I think that will make a difference. The other thing that arose from the studies I've mentioned, Morris et al., again, looking at Jamaican men, she noted that these are community dwelling men. 16% of them were dealing with cancer issues, most of these being prostate cancer. And another 12.6% of them had various genitourinary issues. I quote these numbers to show the high prevalence of genitourinary illnesses that men have, the high prevalence of men's health issues in our community. Yet, for reasons that are best known only by the Ministry of Health, although the University of the West Indies has graduated over 21 urologists since the program in urology started, the urologists have only been appointed to major city hospitals and major urban centers such as Spanish Town. The country hospitals do not, the rural hospitals do not have urologists. And because of that, we see very poor healthcare, or men in these areas experience very poor healthcare. I'll share a very quick story with you. Some years ago, a patient from St. Elizabeth, 65-year-old man, was diagnosed with early prostate cancer, that is prostate cancer still confined to his prostate. And this man had no significant comorbidities. He was a patient who could be cured of prostate cancer. But his general surgeon who saw him and was looking after him recommended removal of his testicles as treatment. His daughter was alarmed at this, reached out to her, a friend of hers who was a GP, and the patient came and saw me. The long and short of it is this man had a radical prostatectomy done, which would have been one of the appropriate choices of care for him. And 6 years later, the man is cancer-free, he is potent, and he is continent. Had this man had his testicles whipped out by a general surgeon in a rural hospital, his quality of life would have been affected. I highlight this example because you can multiply this manifold across the length and breadth of Jamaica due to the maldistribution of urologists. And as I said, I think it's an indictment on us that so many years, over 2 decades after the urology program has been instituted by Professor the Honorable Lawson Douglas, to this day, we do not have urologists across the length and breadth of Jamaica who could improve the quality of care of men's health. So I'm going to leave it there. Those are my initial thoughts. I just want to close by saying, again, we need to do more community-focused interventions rather than have events at Cancer Society or the Pegasus or the conference center. We need to go into the communities and primary health care facilities where men can get their prostate cancer screening and so on is the way to go. Thank you very much.
Yes. Yes. Thank you, Professor Aiken. Strong words, but definitely strong words speaking to many major problems that our men have. And as I sat and listened to all our panelists who spoke in their different areas, whether it related to young athletes and their fears or their barriers towards acceptance of a COVID test result and acceptance of the implications of it, to our young men who are at risk for suicide and all the barriers that they face in testing or seeking care. And then now our men and what are barriers in terms of accessing health care. It just struck me just how many issues our men face on a day-to-day basis. So I'll first open the discussion with Professor Irvin just about our men, the young men who came for the COVID testing. So they subjected themselves to this COVID test, yet despite getting a negative result, they generally just did not believe that the test was positive.
Actually, no, they were positive internationally.
Okay.
We were in Kenya, some of them were in Kenya.
Right.
They tested positive by the RT-PCR.
Okay.
They performed.
Right.
And this was what was frightening. They performed. So when they were randomly tested and they found they were positive, they said, I'm not positive.
Right.
They're lying.
Right.
So when they came and we did the antibodies, and we found the antibodies to the COVID antigen, they still didn't believe.
Right. So did you find that that affected even their adherence to recommendations in terms of quarantining?
Right. As a matter of fact, one who tested positive months ago and was supposed to quarantine came back to Jamaica.
So it speaks to a general issue, even in terms, maybe not just isolated to our athletes, but our younger men in terms of their belief and of the importance and the implications of COVID. And you touched on something that's very interesting. I know it's quite topical now in urology, testosterone and COVID and COVID vaccine. So you did say a few of them, their testosterone levels were lowered.
A little bit lowered.
A little lowered. And I mean, we do not have their baseline, but it is something that is very, very interesting, maybe even to look at in other men. Absolutely. Just interesting. Dr. Thomas spoke a lot about suicide and suicide prevention. And I can't help but mention that as I look on the television on a nightly basis, I see a lot of these ads coming up about online therapists. And it's almost like it has mushroomed during the pandemic, access to therapists. Do you think that that's something that could impact our men in Jamaica who may have barriers to going to therapists if they are depressed or anxious and they're at higher risk for suicide? Is that something that you think would be useful here as we speak of all the things that can be done to improve our assistance to these men with mental illnesses?
Thank you for the question. Yes, I do believe that the online opportunities really provide the space for the man to get more help. What we're actually seeing is that more people in general are using the online services, but the man wants privacy. He wants a context where he is not identified, and he wants to be able to process the issues that he's faced with in a non-threatening, kind of judgmental kind of manner.
Mm-hmm. And I certainly think it's something that would be wise to study. I know we are still in the midst of a pandemic, but the impact or the mental health impact from COVID on our population, a lot of people speak about it, and I see the Ministry of Health has been even advising people about getting help, as depression may seem to be something that persons will suffer from during the pandemic. But whether we have documented any difference during this pandemic or not, I think is certainly something that's wise to do. So I'll ask, there are lots of questions I have to ask Professor Akin. So the big question is, how do we get more urologists out into the region? How do we convince the Ministry of Health that it is important to get more urologists into a St. Anne's Bay hospital, into more urologists maybe into, well, there's one already at Mandeville, into Princess Margaret Hospital, instead of having all these patients coming into Kingston Public or University where there are long delays? What needs to be done from our perspective or any other perspective?
I think we need to convince them with data, Dr. Morrison, because that one urologist in Mandeville serves a population of about 740,000 persons. So can you imagine one urologist is serving a population of 740,000. The entire northeastern part of Jamaica, from St. Anne going right back easterly to Portland and St. Thomas, there is not one single fixed urologist in that region of Jamaica. A study that I did some years ago looking at rural-urban differences in prostate cancer demonstrated that rural dwelling men presented with 70% more advanced cancers than urban dwelling men. And we know that this maldistribution of urologists badly affects the care that patients in the country get, because we see it. This is the lived experience of our urologists. When we see patients who come from the country, they come with more advanced disease. They come with more morbidity due to the disease, and this is preventable by allowing these patients to be able to access urologists by not having to travel all the way to Kingston or Montego Bay. The quality of care would significantly improve.
Absolutely. Absolutely. So there is a comment from someone in-house.
And there are some questions in the chat.
Okay.
So my suggestion that I have as it relates to urologists, I believe that the Ministry of Health should invest in a couple of doctors per year. Say, we will pay for your tuition, pay for you to go to the program, and in return you have to give back, whether it's 3 years or whatever, 4 years, in X parish, and it's rotated that way. Because there's a lot of brilliant young persons, I'm sure, here in Jamaica. A lot of them struggling, can't even make it, who would even like to go through the program and can't afford it. But if we invest in them, it's going to be cheaper than, the struggles and the bondage that is now placed upon the healthcare system here. And then a lot of persons, the outcomes are not just good at all. when, you know, they're made to wait so long and eventually even end up dying. So I think the Ministry of Health really need to invest, even if it's 2 or 1 per year, and said, okay, you're gonna have to give back for what we've paid for your tuition. Serve 3 years down in Hanover, you know, serve 3 years there or 2 years, whatever. And I mean, have it rotating that way. That way the population can be served. Kingston cannot manage the entire, you know.
So the truth is that the ministry does invest in training. The university hospital trains residents every year, and the Ministry of Health also sponsors training for residents every year. So every year in the urology program, which I supervise, we accept at least 2 candidates for urology training. And also every year we have residents who exit the program. So the issue is not a lack of trained persons. The issue is not the lack of desire to go to these places as well. Let me emphasize that. There are many persons who are even from those neighborhoods who have applied, who have sought to get jobs in these hospitals, and they have not been employed.
Why?
So the issue is not that we don't have trained persons, and it's not that they are not interested. They're just not been given posts.
Why?
So that's why we're having this discussion today.
I am shocked.
Right.
I am just totally shocked because I'm befuddled completely. Okay.
Yeah.
Okay.
All right. I know that there are other questions in the chat, so I'm going to allow us to ask those questions.
Should I go ahead and address the questions?
I think someone is going to read them in a few seconds, and then you can address, Prof.
Okay, one question says, does cultural norms also play a part in the disparity between rural and urban areas? Example, elderly rural patients thinking that having stoppage of water is normal in old age.
I think that's for you, Professor Aiken.
Certainly. So cultural factors definitely play a major role in health-seeking behavior amongst Jamaican men. We know, and I know I'm not answering your question specifically, but we know the impact on culture in terms of how it affects our men's willingness to have a digital rectal examination. We know the taboo nature of that examination and the macho culture that men have. I don't know that any study has been done specifically looking at the culture of rural men versus urban men as it relates to their health-seeking behavior. But culture always plays a very important role in men and how they access healthcare. And so I would not be surprised if what you have mentioned, because it is in fact true that some men believe that getting stoppage of water is a rite of passage, and that it is something that they are eventually going to have. I just want to quickly mention also that a lot of men wear it as a badge of honor that they have never seen a doctor in their life. They look on that as something to be very proud of. And so we have some definite cultural barriers, that men have to surmount to improve their health care.
All right, good. Is there another question?
For Dr. Thomas, do you suggest that coping behavior and defense mechanisms are weaker for men than females? And if yes, then what are the factors influencing their coping behavior as per the model suggested?
Okay, well, regrettably, I have to accept yes. Coping mechanisms are less in men. It has to do with socialization. Just those messages that have been incorporated in our lives when we were very young. And we need to begin at the very young. We need to speak into the lives of our men. I used to wake up our boys in the mornings and declare over their lives, mighty men of God arise. And just speak into their spirits from very early and affirm them and avoid the criticisms and to speak positive over their lives. Then there's the socialization. Then we also must accept that men tend to be less open for help. So we prefer to go down to drink. We prefer to smoke. We prefer to go down the road and play some dominoes without dealing with the real issues that are bothering us and really don't get the help. So we have got to help men to connect with their feelings so we can help them to be able to get the support they need to be able to work through. Regrettably, we lack poor positive role models. So the man who is a role model is not necessarily the kind of man who processes what's going on. And there's this macho mentality that big man, strong man don't talk about the problem, man don't cry, that kind of stuff. So we have got to get to the root of some of those stuff as we seek to be able to provide support to men in these days.
Yes.
Is there another element to the question? I think was there another part?
I think that answered it quite well. Are there any further questions online?
Okay, Dr. Thomas, they're asking if there's any study of truth that the COVID vaccine affects the men's sexual performance.
I think that's for Professor Aiken.
Yeah, no, okay, not my question.
So some persons who get the vaccine may become transiently unwell. Some persons who get the vaccine may have flu-like symptoms. They may have fever, joint pain, etc., back pain. If you are ill as a result of getting the COVID vaccine, then we know that things like testosterone acutely decline when persons are generally unwell. So the answer is yes, persons may be transiently affected by the vaccine in terms of their erectile performance. But I want to emphasize that there is no evidence today that the vaccine causes any long-term adverse sexual or reproductive effects. On the other hand, there is mounting evidence that COVID-19 infection has adverse long-term, acute and long-term consequence on male sexual and reproductive health. There is mounting evidence for this. So yes, the vaccine may transiently cause an acute illness, but it is not anything that is going to be permanent.
Mm-hmm. Is there another question online?
Yes, there is another question for you, Professor Aiken. From your review of data available at Jamaica Cancer Society and other registry, what is your recommendations to improve prostate cancer screening for the policy?
All right, so I think from the data that Dr. Morrison has generated, we're definitely seeing a biased population of men coming in for screening at the Jamaica Cancer Society. Because when you compare the PSA levels and the disease stage and so on of these men, it's definitely much lower than men who we are seeing, for example, in our hospitals. I think we need to adopt an entirely different approach in that we need to go into the communities where these men are and interface with them there. We need to make a lot greater use of our primary health care facilities in our communities to encourage men to come in and be screened there and to be seen there. I think we're more likely to capture a wider cross-section of men who are typical of the men with prostate cancer that we see, and less likely to capture men who are generally in better health, like the ones who are seen at the Cancer Society. So I think our community-based interventions that are very much dependent on primary health care are what's needed, rather than having persons invited to come into Cancer Society. Not that we should stop doing that, but I think in addition to that, we need to have a lot more community-based interventions driven by primary health care.
Thank you, Professor Aiken. There's one more question for you. What role are you suggesting for general practitioners and primary care providers in addressing
genitourinary problems among men?
Thank you.
Okay.
Oh, well, they have a major role to play. The primary, the healthcare physicians, the primary healthcare doctors are the first point of contact with the patient. The patient's healthcare providers, the general practitioners, are the primary contact with the patients. We will never have enough urologists, even if we were to train lots more urologists. We'll never have enough urologists to care for men. And so it's a general practitioner who will always be the first point of contact with our patients. And so it is incumbent upon them, the general practitioners, to promote healthcare. And, you know, I must say that a lot of GPs, for example, do not do the digital rectal examination on our patients. And a lot of them inappropriately treat patients in terms of evaluating them for prostate cancer. For example, the overuse of ultrasound to rule out prostate cancer when this has been clearly shown not to be able to do so. Sometimes as well, we are seeing where some GPs hold on to patients for far too long, and when they are referred with PSAs that are closer to 10 or 10 and higher, when these patients had abnormal PSAs from years ago. So I'm not berating our GPs by no means, but I'm saying our general practitioners need to improve their knowledge about caring for our men, especially where prostate cancer is concerned, and they need to refer early and refer appropriately so that we can optimize the outcomes for men folk.
Excellent. Well, thank you so much. Please join me in congratulating and thanking our panelists for really what was an exciting session. Our panelists, Professor Rachel Irvin, Dr. Donovan Thompson, and Professor William Aiken. I think that the information that they shared was certainly current, thought-provoking, if we will, and it leaves us really to think about some other actions that are required from a policy level moving forward. We are now at 24 minutes past 1, and I know we're certainly at least an hour behind, so we're going to close this session, and I will now welcome our moderator for the day.
Good afternoon again, everyone. We want to thank our moderator and panelists for that session, our moderator, Dr. Belinda Morrison, and our panelists, Professor William Aiken, Dr. Donovan Thomas, Professor Rachel Irvin, and for a wonderful set of information and the thoughts that have been generated, and we hope that this will go beyond the thoughts in terms of looking at the different challenges and perspectives that were raised to see how they can be addressed. So at this time, we are behind, and we're going to try and make up the time. So we will start again at 1:30.
Hi, good afternoon, everyone. I'm hoping persons are able to hear.
Dr. Spence.
So, just testing.
Yes, we can hear you.
Okay, great. All right, so good afternoon, everyone, and welcome to this session, scientific session number 5, looking at COVID-19 and chronic non-communicable disease. Just to indicate, we have 3 presenters during this session. The first presenter is Dr. Andre Williams, who will then be followed by Dr. Shanika Davidson, and finally, Dr. Dingle Spence. Each presenter has approximately 15 minutes. And starting with Dr. Andre Williams, he will be presenting a comparison of high utilizers versus low utilizers of healthcare among sickle cell disease patients at the University Hospital of the West Indies between January to December 2019. He's a medical officer who is employed to the Southeast Regional Health Authority, a graduate of the University of the West Indies, where he obtained a Bachelor of Medicine, Bachelor of Surgery degree in 2015. Dr. Williams is currently pursuing the Doctor of Medicine degree in internal medicine. And in his spare time, he enjoys reading nonfiction novels and exploring the rural countryside. So let's give Dr. Andre Williams some virtual claps, as well as applause from the room at Jamaica Pegasus, and welcome him to do his presentation at this time.
All right, good afternoon, everyone. Thank you for that introduction, Dr. Spence. I would also like to thank the Ministry of Health and Wellness and the Organization Committee for the National Health Research Conference for giving me the opportunity to present today. This research was done in partial fulfillment of the Doctor of Medicine in Internal Medicine degree at the University of the West Indies. So the title of the research is a comparison of high utilizers versus low utilizers of healthcare among sickle cell disease patients at the University Hospital of the West Indies. To give some background to the study, sickle cell disease is the most common hemoglobinopathy in the world. A hemoglobinopathy is a genetic disorder affecting the structure and function of red blood cells. In Jamaica, about 10.1% of the population is affected by sickle cell disease, and approximately 18,000 persons are affected, with around 250 infants born annually with the disease. The hallmark of sickle cell disease is what is termed the acute bony painful crisis. It is characterized by severe bony pain that is often unpredictable in onset, but there are known triggers which include skin cooling, emotional distress, and physical exertion. Most patients manage their bony painful crises at home. Of the small subset of patients who present to hospital, an even smaller subset account for the majority of healthcare utilization and costs. These patients are termed high utilizers. To give some statistics, Yang et al. Found that 33.5% of patients accounted for 71.4% of emergency room visits. Epstein et al. Found that the 20% highest utilizers accounted for 54% of hospital bed days. Now, the frequency of bony painful crises is associated with increased mortality, and we have known that for quite some time now. Platt et al. In 1991 showed that 3 or more painful crises for the year was associated with increased mortality. There are varying definitions of high utilizers. The acute events have been defined as either admissions to hospital or acute bony painful crises, and the number of those acute events range from 3 to 6. Most studies investigating high utilizers were done in North America, and consistently what these studies have shown is that high utilizers have more complications of sickle cell disease than other patients. For example, Isiko et al. Showed that high utilizers had more transfusions and lower hematocrit. Carroll et al. Showed that high utilizers had more diagnoses of pneumonia acute chest syndrome, and avascular necrosis of bone. So we designed a study to investigate the phenomena of high utilization among sickle cell disease at the University Hospital of the West Indies. Specifically, we wanted to determine what proportion of patients with sickle cell disease who visited the University Hospital of the West Indies in 2019 were high utilizers, to determine whether there were demographic differences between high utilizers and other patients with sickle cell disease, to determine whether high utilizers suffered from more complications of sickle cell disease or had lower hemoglobin than other patients with sickle cell disease, and finally, to determine whether high utilizers were prescribed more potent opioids than other patients with sickle cell disease. So the study was a cross-sectional study. We define high utilizers as patients with sickle cell disease who were referred 3 or more times to the internal medicine on-call team for unresolved pain. The protocol is that patients with sickle cell disease are referred to internal medicine if their pain is unresolved post 3 doses of injectable opioids. Patients with less than 3 referrals were classified as low utilizers. The source material for the study were the Dangerous Drug Administration book. Now, this contained a detailed record of the type and dose of opioids prescribed to each patient. The patient's dockets were also used, and of course, the internal medicine on-call referral book, which has a detailed record of all the referrals received from accident and emergency. The independent variables were age, sex, the use of morphine or petidine, the presence of disease complications, and the hemoglobin at presentation. Subjects were categorized into binary variables as low and high utilizers. The difference between low and high utilizers and each independent variable was assessed using univariate mixed effects logistic models. Now, this statistical method allows us to account for multiple visits by the same individual, so each visit is not seen as an independent occurrence. The presence of confounders, such as chronic joint conditions, was also assessed. Statistical significance was set at p less than 0.05. Now to our results. Now in the sample, there were 144 individuals, 41 of which were high utilizers. For the calendar year, we received 920 referrals from accident and emergency for unresolved pain among sickle cell disease patients. 799 of these referrals were for high utilizers. So in effect, we had 28% of the sample were high utilizers, and they accounted for the vast majority of the referrals, which was 87% of the referrals. Now, this is a table with our descriptive statistics. Now, at the top of the table, you see the patient's demographics, particularly the age and sex. The hemoglobin is the hemoglobin at presentation, and the sickle cell disease complications that we looked at were avascular necrosis of the femoral head, leg ulcers, sickle nephropathy, and our confounders being chronic joint conditions. There is no difference between high utilizers and low utilizers in the categories assessed. Now, this table shows our univariate mixed effects logistic regressions, where we compare the different parameters amongst high and low utilizers. I'm bringing attention to the far right-hand corner of the table, where you see our p-values. And the p-values, as you see there, were not statistically significant. In other words, there was no difference between high and low utilizers in terms of the demographic variables that we assess, the presence of chronic complications of sickle cell disease, or the opioids prescribed. Our study was a retrospective study, and being a retrospective study, we depended on the accuracy and completeness of the source materials that we use. In addition to that, we use the steady-state hemoglobin. We use the hemoglobin at presentation. The steady-state hemoglobin was not available And prior studies done on the topic, they had used the steady state hemoglobin. So comparison as it relates to hemoglobin between our study and other studies could not be carried out. In addition to that, only visits to UHWI were included, so it's possible that patients may have presented to other healthcare institutions for management of their painful episodes. So high utilizers comprise 28.5% of the study population, however, accounted for 86.8% of the referrals. And this result was consistent with multiple previous studies done on the subject. High utilizers were similar to low utilizers in terms of the demographics, the presence of complications of sickle cell disease, the type of opioid prescribed, and the hemoglobin level. Particularly as it relates to the presence of complications of sickle cell disease, this is different from prior studies done on the topic, where these studies had shown that high utilizers had more complications of sickle cell disease. Now, in light of our results, which show that there are no clinical or hematological differences between high and low utilizers, we intend to do a prospective study to examine, one, the patient's subjective experience of pain, specifically to see if there are any features suggestive of opioid-induced hyperalgesia. Opioid-induced hyperalgesia is a paradoxical phenomenon in which patients who are receiving opioids actually experience more pain. In addition, in that study, we would pay more attention to other demographic parameters, particularly the educational level and the socio-demographic characteristics of the patient. We strongly believe that further studies need to be done on this subject, as we believe any information garnered may be able to put into effect targeted strategies to attenuate the significant morbidity and mortality among this group of sickle cell disease patients. So I'd like to thank the staff at the sickle cell unit, particularly Professor Madden and Dr. Ramsey, who played a significant role in this project. In addition to that, my academic advisor at the University of the West Indies, Dr. Swain Gardner, who also played a significant role in this study, the staff at the medical records, and finally, people living with sickle cell disease who present to the University Hospital of the West Indies. Thank you, and I appreciate any questions.
Just to remind all persons who are online as well as in the room that question and answer segment will be taken after all three presentations have been completed. So just asking person to hold those questions until that point in time. And so now let me invite our next presenter, Dr. Shanique Davidson, who will be presenting on the role of artificial intelligence and radiomics in predicting high versus low-grade gliomas from MRI images at the University Hospital of the West Indies. Dr. Davidson is a final year radiology registrar at the University of the West Indies, Mona. She is also a radiology fellow at the Nottingham University Hospitals NHS Trust and works at the Queen's Medical Centre and Nottingham City Hospitals. While currently participating in radiology research in the UK, one of her main goals is the introduction of artificial intelligence to radiology practice in Jamaica, as she is passionate about innovative research. Dr. Davidson has been enthusiastic about writing since the age of 13, and some of her fictional stories were published in the International Collegiate Quarterly for Seventh-day Adventists. Please put your hands together and welcome Dr. Shanique Davidson.
Good afternoon, everyone. I would like to thank the Ministry of Health for giving me this opportunity to make this presentation. This research was done in partial fulfillment of the DEAM of Radiology program. Sorry, just give me a second. Good afternoon, everyone, and a special good evening to my colleagues here in Nottingham, UK, who have joined in to listen. So let's begin. The role of artificial intelligence and radionomics in predicting high-grade versus low-grade gliomas from MRI images obtained at the University Hospital of the West Indies. A brief overview into this research. We will start by looking at introduction and background, aim and objectives, methods and materials, results, conclusion, and then some acknowledgements. So, artificial intelligence. What comes to mind when we hear artificial intelligence? So some persons believe that artificial intelligence, AI, will be replacing humans by undertaking intelligent tasks that were once limited to the human mind. However, there is another school of thought that suggests instead of being a replacement to human mind, AI can be used as an augmentation tool to human intelligence. There is no standard definition available for artificial intelligence. However, it is a field that incorporates computer science and robust data sets to enable problem solving. It encompasses subfields of machine learning and deep learning, which are frequently mentioned in conjunction with artificial intelligence. As we see here, deep learning is a subset of machine learning, which is also a subset of artificial intelligence. AI algorithms seek to create expert systems which make predictions or classification based on inputted data. Radiomics extract a large number of quantitative features from medical images using data characterization algorithms. These features are used to uncover disease characteristics or patterns that are difficult to identify by the human vision alone. Machine learning techniques can then be applied to these to produce a desired output. A bit of a background. So why gliomas? What's the fuss about gliomas? Well, gliomas account for approximately 78% of primary malignant brain tumors in adults worldwide. And glioblastoma multiforme, which is a high-grade glioma, it is very aggressive and the most common brain tumor worldwide. MRI imaging has been used to identify gliomas over the years. And many believe that with just contrast enhancement alone, they can predict the grade of these gliomas. However, there have been papers that have been published on MRI features that can aid in determining whether gliomas are high or low grade. However, even the most experienced radiologists cannot predict accurately whether a glioma is low grade or high grade. There is a view that enhancement, as mentioned before, is a sign of a malignant type of glioma. However, up to 48% of non-enhancing gliomas are malignant, and several enhancing gliomas have been reported to be benign, as a study quoted by Scott et al. In 2002. Therefore, contrast enhancement is not a reliable predictor of high-grade gliomas. As such, a study that can reliably predict a high-grade from a low-grade gliomas from pre-operative MRI brain images has significant clinical relevance. The aim is to use artificial intelligence and radionomics to distinguish between high-grade and low-grade gliomas before surgery, so from the preoperative MRI brain images, and to develop an AI-based tool and a classifying tool for these gliomas. And then to test the effectiveness of the models by comparing the classifier's diagnosis with that against the histopathological results obtained after surgery for these patients. The study was a retrospective study, and the tool was built using artificial and radionomic features as mentioned before. For any AI model, there has to be some training involved. And for our model, we trained the model with images obtained from the BRAT 2019 dataset. So this dataset consists of MRI brain images of gliomas that were labeled by expert board-certified neuroradiologists, and it's available in the repository of the Cancer Genome Atlas. We also use the UE Brain Tumor Registry, and this includes patients with intracranial tumors from 2006 to present that were scanned at the hospital. The images were manually segmented and used to test the AI-based classification tool as well as the segmentation tool. This is a schematic diagram of a unit model that was employed in the AI segmentation tool. We input an image here and an output segmentation image is performed. This is an MRI axial brain image showing a glioma within the left parietal lobe, and this is the mass that was obtained after segmentation. The next slide will give a brief demonstration of the process of segmentation as well as classification by my co-researcher, Mr. Jermaine Samuels.
Welcome to the glioma classification and segmentation dashboard demonstration. In this video, we show how we can use a dashboard to predict the classification and segmentation of gliomas. This tool actually showcases two functionalities, the first being the patient analysis, which allows us to upload all the images or scans for a patient via a folder and then perform the analysis. Secondly, we have the prediction tool, which allows us to upload random images from a patient or patients, and then that will allow us to do the prediction for segmentation and classification. The difference between both tools is that the prediction tool will display the results for gliomas with the highest cross-section first, while the patient analysis tool is equipped with expert labels that shows where the glioma lies for comparison. Let's start off with the patient analysis. Once we select patient upload, it will populate a window that allows us to select a particular patient that we would like to analyze. Let's start off with patient 1 and then select folder. You'll be prompted that the images were uploaded successfully. Then you can select patient analysis. The images may take a while to populate. However, once they do, they will appear row by row, one at a time. At the very left, we can see the original image, which is the actual scan being analyzed. Next to that, we have the original mask, which is the label provided by expert indicating where the segments lie. And then we have our predictions, which is the predicted glioma for the next 3 columns, which is predicted glioma, binary prediction, and overlay. Now, we can see some delocalization for the predicted glioma. So we have a binary prediction to show the intensity, but in either case, the intensity indicates the highest probability where the glioma lies, while for the overlay, it shows the actual image that is covered with a segment for the glioma highlighted in red. Now, this allows us, or the model allows us to actually view the segments for different planes for MRI scans, whether sagittal, coronal, or axial. The next tool we can now look at is the prediction tool, which again allows us to upload images. So we can navigate to the images that we want to analyze. We can select one image and then select open, or we can select 2. In this case, let us select 2 images and then select open. You will be prompted that the images are successfully uploaded, and then we can again select full prediction. The images may take a while to load once again because of the analysis being done. However, once they do, they will populate 1 row at a time. Again, we can see the predictions here. We have 2 predictions for 2 scans, and we can see the prediction as a high-grade glioma for both the predicted glioma column, the binary prediction column, and the overlay. It's important to note as well that you can also download the results should you wish to share the results with your team members across different medical departments. And that will be populated in the form of an Excel file. And with that being said, that concludes the total functionality for predicting the classification and segmentation of gliomas using a dashboard. Thank you.
So the results obtained thus far from our segmentation and classification tool, as it relates to segmentation tool, there's a 95% accuracy when using the images from the BATS data set to test the tool. There is a 70% accuracy when using the images from the UE brain tumor registry. As it relates to classification, we obtained a 92% accuracy when we use the images from the BATS dataset and 63% accuracy when using the images from the UE dataset. I would like to emphasize that with ongoing training of the developed tools, the results will improve. Just in the past 2 weeks, since the submission of this abstract, it had showed marked improvement in terms of accuracy of segmentation. It was initially 75% when tested with the MRI images from the BATS dataset. And as we can see now, there's a 95% accuracy. Therefore, we are expecting improved results with ongoing input and training. Some reasons behind the differences in results or limitations that we recorded in this study was one, several images from the BATS dataset were excluded from the training dataset due to noise and the reduction in the resolution of these images, thereby subtracting these images, and this resulted in a reduced number available for training and affected the overall performance of the tool. Another limitation was that we were not able to apply the same transformation to the UE images as what was applied to the BATS dataset for training to achieve the same normalization of these images, as the information for their pre-processing were not available, although their images were. We are still looking into different pre-processing techniques to apply to the UE images that will give better results, and thus this project is ongoing. The last limitation that we noticed is that there was a limited number of patients available in the UE registry for low-grade gliomas, which subsequently allowed for some bias towards detecting high-grade gliomas due to a larger number available. So in conclusion, this research has shown that artificial intelligence is beneficial for medical practice in Jamaica. Though the work is preliminary and the test data set is small, the predicting power for this model shows promise for classifying gliomas without invasive surgical sampling and indicates that it may be useful as a diagnostic tool. This is relevant to daily radiology, pathology, and neurosurgery practice. Here are a few of my references, and I would like to acknowledge my co-authors on this, Mr. Jermaine Samuels, which we heard from, Dr. Andre Coy and Dr. Peter Johnson. Special thanks to Dr. Keisha Thomas and Mr. Nicholas Brown for helping to gather these data. Thank you very much. Thanks for listening.
Thank you very much for that, Dr. Davidson. Very innovative and interesting, I'm sure. And I'm sure persons are anxious to be able to ask questions. But we are proceeding with the third and final presentation in this segment from Dr. Dingle Spence on the WHO Global Evaluation of Palliative Care of 6 countries, looking at the results for Jamaica. Dr. Dingle Spence is the director of the Jamaica Cancer Care and Research Institute. She's a Jamaican physician with training in both clinical oncology and palliative medicine. She is the senior medical officer of the Hope Institute Hospital, Jamaica's only dedicated oncology and palliative care unit. She also serves as a board member of the International Association for Hospice and Palliative Care, president-elect of the Caribbean Palliative Care Association, and as associate lecturer at the University of the West Indies and the Cicely Saunders Institute, King's College, London. Dr. Spence has a special interest in providing access to palliative care education for providers in small island nations and other countries in the Caribbean region. Please help me to welcome Dr. Dingle Spence, who will now do her presentation.
Thank you. Good afternoon. I'm just trying to share my screen now. Let's see if that will work. Okay, I hope everybody can see that. So thank you very much to the Ministry of Health and Wellness Research team. And I know time is short, so I'm going to jump straight in. So I have no disclosures. And this is an overview of what I'm going to speak about. So a little background and introduction about where palliative care sits globally, and then moving into the study itself, materials and methods, results, conclusions, and so on.
Sorry,
I just really wanted to...
Is it possible for you to put it on slideshow so it projects better, please?
On slideshow, I'm sorry, I thought it was. Sorry. There we go. Is that better? Thank you.
Yes, it is. Thank you.
Okay, sorry about that. Okay, so just to start really with the definition of palliative care. And really the bottom line is that palliative care is considered primarily a response to suffering. And then there's many definitions. I was part of the consensus making this definition, so that's why I like to own it. So palliative care is an active, holistic care of individuals across all ages with serious health-related suffering due to severe illness. And note, it doesn't say cancer in particular, although a lot of palliative care in Jamaica is focused around the oncology patient because we do lead it from the Hope Institute Hospital. So it's the care of people with serious health-related suffering due to severe illness, and especially of those near the end of life. And of course, if you're relieving suffering, you hope to improve the quality of life for patients, not just them, but their families and their caregivers. Oops. So just again, to give you a bit of a global picture, that in 2002, palliative care was recognized by the WHO as a human right, which means that all of us should have access to good quality palliative care. In 2007, the World Health Organization published a public health strategy for how to deliver and develop palliative care in your country. And we can mention that a little bit in a minute. And then very importantly, in 2014, the World Health Assembly, which advises the WHO and where all of our ministers of health attend and vote on resolutions. So the resolution, strengthening of palliative care as a component of comprehensive care throughout the life course, was adopted unanimously. So it means that our Minister of Health at the time raised their hand to this and agreed that they would work towards helping embed palliative care in our health system. So I'm just giving you this background so that we can hone down on why this study, why Jamaica. So the WHO, based on the resolution, had a lot of things they agreed to do, and the countries themselves agreed to do certain things. So one of the things the WHO said is, look, we know a lot of people don't have palliative care in their countries or very insufficient. Can we find some evidence-based models that work, especially in low and middle income countries where a large proportion of people, particularly in the oncology setting, may present with metastatic disease, There's a lot of untreated HIV and AIDS in many LMICs. And so it's how do we find a model of palliative care that might be able to be applicable in many different countries? So bearing that in mind, we now just turn briefly to the public health model. And this has 4 prongs. So we need to have educated health professionals in order to deliver the care for patients and families. But one of the real things about being able to do palliative care is to have essential medicines. And those medicines would have opioids at the top of the list because pain relief is critical to not just cancer patients, but many of our palliative care patients across the other NCDs. So there's no point in having opioids or other medicines if you don't have an educated population. There's no point in having an educated professional population if there's nothing for them to use. So it's not just medicines, but it's also, you know, simple basic equipment. We also need to have policy, because if our Ministry of Health is not buying in to palliative care, then we're going to be just spinning around on a dime and not really getting anywhere. So I'm happy to be able to report that we're on the verge of being able to develop a national strategy for palliative care with buy-in from our Ministry of Health. So then you may have all of those things, but then you actually have to do it. You have to implement your palliative care. And this is again where this now arises. We need some demonstration projects. And this is what the WHO is saying is, let's pick some demonstration projects from around the world, help measure what those people are doing and see if it's applicable to other countries and other situations. So in order to build the evidence base for palliative care models of delivery, the WHO decided to identify a demonstration site in each of its 6 global health regions. And at the Hope Institute Hospital, we were absolutely privileged to be chosen as the demonstration site for the Americas, that is in the PAHO region. And just to say the other country sites involved, you can see there Oman, Belarus, Zimbabwe, Vietnam, and Thailand. And if you looked the global health regions, you see that each of those countries represents a health region, or dwells in a health region, I should say. So what did we do? So it's a mixed method study. We are using both qualitative and quantitative data. And that obviously gives us a much broader understanding of the kind of landscape that we're looking at. We're recruiting 134 patients and their caregivers. So we're talking about 134 dyads, if possible. And to date, we have recruited just over 80 patients, but when we were doing the data analysis, we only had about 50 people enrolled. And it's questionnaire-based, it's just interviews, there's no medical interventions apart from the care that we give. The study itself is questionnaire-based. The inclusion criteria depends both on the patient, the primary caregiver, and the staff treating the patient. So patients need to be 18 years or older, they need to be new to our palliative care clinic, and they needed to be able to identify a primary caregiver. And that primary caregiver was really an unpaid member generally of the household who was providing all care, physical, practical, and often giving emotional support. And the staff who were delivering the care from our medical team at Hope obviously needed to be involved in patient care and needed to have been working with us in palliative care for at least 6 months. And the exclusion criteria, fairly simple, if people were cognitively impaired and not competent to answer the questions and were under 18. So each patient in the study would have at least one physician who's following them through and caring for them, and at least one primary caregiver, although that's not always possible. And sometimes we did recruit patients who actually didn't have a caregiver, which is something that would be interesting to report back. You know, how frequent was that? And how difficult is it for somebody to manage when they're on their own? So this is just a very brief flow chart. So we admit the patient into the study. Obviously, they need to consent. We do the demographics. And then basically we follow them through. We see them monthly, either in a physical consult or on the phone. And we speak both to the patient and to the caregiver and gather the data each month. So we follow people for either a year or until the death of the person that was recruited. The other thing that we're doing is we have, I think we may say this in the next slide, that's right. So the quantitative arm is questionnaires. We're using Likert scales, 0 to 5. And the qualitative arm, we are picking 5 patients and 5 caregivers to interview them. So it's 10 interviews effectively to get a broader understanding of how they feel about the care they're receiving. So just to give you some results, they're very, rudimentary, because we're just really starting to collect data from the study and compile it. So at the time, we had 51 patients and 42 caregivers, and the mean age of the patients was 60, with quite a wide age range from early 30s to mid 80s. These are all cancer patients, by the way, because we are an oncology facility at Pope Institute. Most of the caregivers were children of the patient, and then the next most frequent type of caregiver would have been a spouse or a partner. And as you can see, there's a variety of other caregivers represented there. The primary diagnoses, cancers of the GI tract. So this clinic, the most patients that we recruit the bulk come from the KPH Palliative Care Clinic, and a smaller number come from the Hope Palliative Care Clinic. So we see a lot of people at KPH with colorectal cancer, and obviously breast is the most common cancer in women. We see a lot of women with cervical and endometrial cancer as well. So as you can see, those are the 3 most commonly represented cancers in people being referred to our palliative care service. We also assess what we call performance status, and we use what we call a Karnofsky performance scale, that at 100%, you're absolutely fine, and at 0, you have passed on, and most people would fall somewhere in between. So just to say that a majority of our patients had a reasonably good or quite high performance status. And then we had another mini peak here where people are much less well and need a lot more care and input from their caregiver. We as the physicians are asked to decide whether we think people are stable, unstable, or very unwell when we first see them in the clinic. And I'm very proud of our referring clinicians that the patients that we are seeing now are actually stable, because when I first started doing palliative care in Jamaica in 2002, 2003, most of the people that I was referred would have fit into this pillar. People were within the last 48, 72 hours of life. So I'm really have to say again, I'm so pleased that people now understand that early referral to palliative care is what we should be doing. So we're seeing the patient in a relatively stable state, and we can then follow them on their journey rather than meeting them in the last day or 2 of life when it's really almost more the caregiver that you're supporting at that time. So the initial findings: pain, most burdensome symptom. Almost 50%, 45% of patients, this is the first interview, said pain was their biggest problem, and poor mobility was the second most biggest concern, and that they would say was primarily due to pain. And then a whole raft of other symptoms reported: shortness of breath, weakness, constipation, poor appetite, and so on. Interestingly, most people reported having good family support, and were not that worried about their illness, particularly at the time of their initial interview. Caregivers reported that they did have adequate information about the patient's illness, felt confident about the care that was being offered, but did about 50% of the time worry, which is not surprising really, about their ill relative. So, small amount of data so far. We could have told you an awful lot, but it's a short presentation. So just in conclusion, really, to say that pain control remains a priority for patients with advanced disease, and the relatives worrying about their ill family member was another significant finding. even though they felt confident in the care that was being offered. There's obviously a multiplicity of symptoms that people present with, and so a palliative care team needs to be confident and competent in managing those symptoms if you're going to relieve suffering. And there seems to be one thing that was left off here, where we have caregivers expressing confidence in the team that was offering care. And so that's really the presentation. We hope to have recruited everybody by March 2022, and then we will be able to give you much more data. And we also hope that one of the things we'll discover is that people are happy with the care they're getting from the Hope Institute Hospital team. And we also hope that as we go towards building out a national strategy for palliative care, that we can reflect on this study and look at what people say is the most important thing to them during their care, during the last 1 year to 6 months of their life. And we can build on that so that we put care into the system that people want rather than what we think is important. And here are my references. And I have to say, I must thank also Dr. Keisha Thomas, who helped with the previous presentation, who helped to put this talk together and is one of our research associates at JACRI. So thank you very much.
Thank you very much, Dr. Dingle-Spence, for that presentation on palliative care. So that would have concluded all 3 presentations in this scientific session number 5, looking at COVID-19 and chronic non-communicable diseases. So I just want to officially thank all the presenters for very interesting presentations being made during this particular session. Dr. Davidson looking at AI and radiomix in relation to gliomas, and Dr. Andre Williams looking at the utilization of our healthcare services by sickle cell disease patients. So I'm going to open the floor now for questions. I already see one hand raised, and so I'm going to go to that person first. But just remember that you can also type questions into the chat, and I would ask the team that is on site if there are any questions or any comments that persons from within the room want to make, to please let me know and indicate. So let's start with Dr. Tamika Royal Thomas. You want to go ahead?
Yes. Good afternoon again, everyone. Just lovely round of oral presentations again. So I want to congratulate all of you who spoke. I have questions for each person. First, to begin with Dr. Andre Williams. I wondered, do you think that the non-statistical significance was, what do you think would cause the non-statistical significance in your study? What could you attribute that to? Or do you think the results were just the results?
Thank you for that question. So, well, the results were just the results. The results indicate that high utilizers and low utilizers, there is no significance in terms of chronic complications. In the conclusion, I implied that opioid-induced hyperalgesia might be playing a role. In a future study, we'll definitely look at that. In addition to that, a topic which a lot of us have probably not assessed in our setting, and that is really the prevalence of opioid dependence among these patients. So those are 2 topics that we hope to look at in a future study.
So, Dr. Williams, you have me curious. You don't think the retrospective aspect of the study and the sample size would affect your results?
So looking at the sample size, 144 patients, there are quite a number of referrals, 970, and when we compare our study to other studies done on the topic, our sample size was actually one of the more larger sample sizes. So it was fairly a large, a fairly good powered study. So we actually don't think the sample size played a role.
Okay, thank you very much, Dr. Williams.
You're welcome.
All right. My next question goes to Dr. Davidson. Very interesting presentation on AI. I'm going to ask you, how do you think that, how do you think that UHWI can actually increase the accuracy in terms of classification of the MRI?
So first thing is to improve the number of patients that we scanned. Currently, we have one MRI scanner, and that results in a reduction of numbers of patients that we have in terms of diagnosis. In terms of AI model, it works on a computed amount of images. So the more images you have, the better the accuracy, the better the training. And if we have more MRI scanners or to scan more patients, this would improve our results significantly.
Okay, thank you very much, Dr. Davidson. All right, and on to Dr. Spence. Very interesting and just very applied and empathetic in terms of the nature of the study, Dr. Spence. And you said that it's a mixed analysis in terms of the study, which is quite good that you have both the qualitative and the quantitative aspect. You also mentioned that it was preliminary study. At this point in terms of the study, Dr. Spence, is there anything that you would want to add or do differently or add to make sure that you're getting accurate results or results that really speak to help in terms of palliative care?
So thank you for that. I think now we're just over the halfway mark. What I plan to do is to just go back to my team and make sure that they feel that they're consistent in the reporting of the performance status and the particular improvements also we hope to see. Because what I was reporting was the responses from the first interview. And obviously, I wouldn't want to know that 6 months into being in palliative care that you were still telling me that half of the patients were still in pain. So, as I'm saying, what we were reporting is the first data. So we personally, how it is in Jamaica, we all work so hard and we don't collect a lot of what we do. So for us, not just globally, but for us very locally, we're very interested to see, how do people think, are we actually making a difference? We think we are, and anecdotally we kind of know we are, but it would be really good to have some objective measure. And I just see if I can say, I think that there's a question in the chat. Do you think the focus on COVID-19 compromises curative palliative care? So if I could just answer that, because I think that's a really important question. And the answer is absolutely. Curative care, because there's long delays, much longer delays for people to get their biopsy done. They keep getting turned back, or they don't even want to come to the hospital because they're so afraid they might get sick. So we hear that all the time. And then in terms of the palliative care, remember, if you're coming for palliative care, you're already sicker, and it's already a bigger deal to come. And so I think that there may be a lot more people out there who are suffering because they're too afraid to come. And so I think COVID has across the board damaged everybody. People who could be cured are showing up with metastatic disease, and the people who could benefit from excellent palliation are not coming because of their own fears. So.
Thank you.
Thank you very much, Dr. I think that was Dr. Royal Thomas. There seems to be another question in the chat, I think, for Dr. Spence.
So yes, it says, how do we predict that study will impact cancer care in Jamaica's setting?
Yes.
So I think we should just be clear that this is not curative cancer care that we're looking at. We're looking at palliative care. And as I said earlier, I do hope that the results will be able to highlight both what patients need, what caregivers need, and how they felt that care was being delivered by us, because clearly we're not perfect. And we would like to know how we can meet people's needs better. So we're very hopeful that at the end of it all, we will have data that can help inform our forward planning in terms of not just palliative care, but oncology care delivery as a whole. Thank you.
Thank you, Dr. Spence. Are there any more questions? I don't see any additional hands raised. Yes, Ms. Errol Williamson, would you want to go ahead, please? Or is that an old hand? I'm not sure. Okay, hand is down, so it was an old hand. Arlene Henry Dawkins, your hand is up. Would you want to go ahead?
I'm sorry, that was a mistake.
Okay, Mrs. Henry Dawkins, no problem. Dr. Spence, I think there's something else in the chat. Are you seeing that comment?
Yes, from Dr. Hilton Connell, who I have to big up, who is my batchmate, so we're still around 30 odd years later. Yeah, that's a very good point, Doc. What Dr. Hilton Kong is saying, that by virtue of COVID and other conditions that may affect palliative care needs, do we think this is a major limitation to the results of the study? And what do I think about that? I think that you may be right, and that some of the iller patients may not be coming. Like, for instance, we had a clinic today at KPH. We had 8 or 9 new patients, and only 4 of them came. Now, is that because the other ones are just too sick to travel? Or, in which case you wouldn't come anyway? Or is it that they're very ill and they're fretting to come to KPH? I have a lot of people saying, no, Doc, I'm not going there. So I don't think we really know how much COVID has impacted the amount of people that are turning up for clinic. But I would say we have a greater absentee rate of our new patients right now than we would have had before COVID. So we'll probably need to comment on that when we get to our discussion in the paper.
Thank you, Dr. Hilton Conran. Thank you, Dr. Dingle Spence. So I'm not seeing any more questions in the chat, nor am I seeing any additional hands raised. Okay, she just messaged again.
A lot of the follow-up is done by phone. So yes, we do call people regularly.
Okay, thank you, Dr. Dingle Spence. So a very engaging session, I think we would agree, colleagues. Thank you so very much to all our presenters, Dr. Williams, who is on site, Dr. Davidson, who I'm assuming is in the UK. Thanks for staying up this late to participate. And Dr. Dingle Spence, as always, a stalwart in palliative care here in Jamaica, and excited about the research and the progress that we intend to make. Very engaging, very informative. Thank you, everyone. And so it has been my privilege and pleasure to chair this scientific session number 5. And so now I'll hand over back to the team at Jamaica Pegasus. Thanks again.
So I think the day has been well spent. Thank you very much, Dr. Spence, for taking us through a very engaging session on COVID-19 and chronic non-communicable disease. This is the last presentation for today. We start again tomorrow at 9 a.m., but I want to highlight something very special, very new in our agenda. Tomorrow we'll have breakout rooms, sessions, and there are 6 institutions that are highlighted: Jamaica Statistical Society, Caribbean Institute for Health Research, Nurses Honors Society, Michael University College, Violence Prevention Alliance, University of Technology. So there are 2 opportunities for you to select institutions that you would like to network in. And so that's at 10:30 to 11:30. So one session is 10:30 to 11, and then the other one from 11 to 11:30. So I think this should be interesting, so let us try that. And we want to thank you all for your presentation. All the sessions went very well, and we'd like to thank all the presenters, the moderators for today, and have a good rest of the day, everybody, and see you tomorrow. For all in the room, coffee break. Please have it before you leave.
At all times, masks should never be worn over the head, under your chin, below your nose, or hanging from your ears. Recovery from COVID-19 can take up to 60 days or more. The mask or the ventilator? You choose. A message from the Ministry of Health and Wellness.
From worry over your finances to mask wearing and physical distancing from your family and friends, your concerns about COVID-19 may be many, but you can overcome. Take care of your mental health. Keep a journal. Talk about how you're feeling with someone you trust. Exercise. And yes, take the time to smile.
Hello. Yeah, you. Hold on. And a pandemic winner. You're not wearing a mask, you're not washing your hand, and you're not keep the required 6 feet distancing from other people. And what could I really cause you? You need to stop it. That no mask, no wash, and no distance something there, nah keep. You know what keep? COVID-19. Yeah, it not gone nowhere. COVID-19, they are same way. So here what you are going to do for all of we. Wear your mask, wash or sanitize your hands pan a regular, and yeah, keep your distance, please. And thanks.
Hello, Jamaica. I'm Dion Jacksmiller. It's unbelievable to me whenever I buck up somebody who is still asking if COVID-19 is real. Because my doctor died of COVID-19. I had COVID recently, and it was a severe case. Most of my lungs were affected. I am so grateful to be alive. Take COVID seriously, guys. Some people won't be affected, that's true, but others may have long-term effects, and some people will die. Let's do all we can to protect ourselves and to protect others.
A message endorsed by the Ministry of Health and Wellness.
Severe pains, shortness of breath, worsening with fever, lack of appetite, extreme weakness, and overall grazing beside death's door. This was my experience with COVID-19. Hi, I'm John, and I'm so thankful that I survived COVID-19. As an asthmatic person who lives alone, I know that COVID could have claimed my life. Listen, don't drop your guard with COVID-19. It only takes a second for you to catch a virus. Initially, I thought I had the flu until things got worse. Don't leave your mask, wash your hands as often as you can, and always keep a physical distance from others. And I want to tell every Jamaican to choose a vaccine before COVID chooses you.
A message endorsed by the Ministry of Health and Wellness. Healthcare workers are working very hard to ensure lives are saved and people recover quickly from COVID-19. But their work is becoming harder because you're not wearing your mask, washing your hands with soap and water, or using hand sanitizer, and you are not maintaining physical distance. Let's limit the need for hospital beds and ventilators. Do the right thing. Cover your nose and mouth with a mask. Practice good hand hygiene and maintain a physical distance of 6 feet between you and others. COVID-19 is not over. Protect yourself while protecting others. A message from the Ministry of Health and Wellness.
Become the hero on the scene by taking the COVID vaccine. Become the hero on the scene by taking the COVID vaccine. Get vaccinated as soon as you get all the facts. Don't listen to the rumors. This vaccine might just make it possible for teachers to sit face to face with schoolers. This vaccine make it safer for everybody, from the young to the young.
So we are now at the Good Samaritan Inn, which is one of our primary locations today for the first vaccines to be administered to frontline workers and vulnerable groups. So far it's been a good day. We started at 8 o'clock, it's now 10 minutes after 10, and a number of persons have gotten their vaccine, including public health nurses, President of the Nurse Association, former Prime Ministers Golding and Pattison, and many others. It has gone smoothly so far.
Get vaccinated as soon as you get all the facts. Don't listen to the rumors.
I'm encouraging all Jamaicans, healthcare workers, frontline workers, elderly, all persons with comorbidities who are going to be offered the vaccine. I know that there is apprehension out there. I know that persons are afraid. Some persons will tell you don't go. They say I'm not going to go. But I am encouraging you, not just as a healthcare worker, but as a regular Jamaican, protect yourself from COVID-19 infection.
Get vaccinated as soon as you get all the facts. Don't listen to the rumors.